We are live. So good afternoon and welcome to bill hearings to the House Health and Government Operations Committee. It is 1:04 in the afternoon. I'm your chairman, Jocelyn Pena-Melnick, joined by my wonderful vice chair, Delegate Bonnie Carlson. I'm going to go through some of the quick rules here. I kindly ask for your patience if we encounter any technical or streaming issues. I'm going to do this myself. Please set your electronics to devices to vibrate. Otherwise, you're going to be embarrassed with your music choice. As a reminder, there's no food or drink allowed in the gallery. Staff cannot and does not have the time to clean. They're very busy, okay? You will see that we get to drink some, but it's because we sit here for hours, okay? Now I'm going to go through the rules about the testimony. The bill sponsor and the sponsor panel will come and sit right there in the middle. The testimony will be favorable with amendment, and unfavorable. I try to be balanced when we have too many favorables and just a few unfavorable, just to be fair. We also have virtual witnesses in this committee, and they will come as well. If there are a large number of witnesses, I will alternate, and I make the decision of what bills go first or second, depending on, if you're wondering how many witnesses are there, right? It's not fair to have someone who only has one witness wait to the end. Now, however, that changes sometimes because our, my colleagues have bills hearings in other committees. And if you don't see them here, it's not meant to be disrespectful. They have hearings in other committees, or they have to go to the back and do something, but they'll be back. They have access to the whole file, and they do read it as well. In this committee, I have chosen not to time the sponsor. But that doesn't mean that you can take advantage, okay? Don't make me have to cut you in the middle of your testimony. Cut you off. You guys are violent. No, just kidding. Woo. And you are violent. No, just kidding. Cut you off in the middle of your testimony. The person who's not the bill sponsor, the other witnesses, the panelists, you do only have 2 minutes. 2 minutes to present your testimony. When you hear the timer go off, please wrap it up. I don't want to interrupt you. And also for the committee, thank you for your hard work. I mean, look, all of you are here. You've been working really hard. I appreciate you. Please only adhere to the one question, per panelist. And please keep your question brief. Members of the public are able to view us live stream and on the Maryland General Assembly website and YouTube. Also, this year we have something new that came out of this committee, which is the closed captioning, and which is wonderful. However, it picks up your side conversations. You don't want it out there, don't say it. Okay, now this is the bill order for now at 1:08. It may change later. Do not take it personally. We're going to start with Delegate Solomon, followed by Delegate Stein, which is actually our Speaker Pro Tempt. Delegate Stein, followed by Delegate Kipke, 828, 933, 939, 718, 1007, 936, and 974. Again, that order may change. Let's actually start with House Bill 859, Delegate Solomon, access to health insurance for child care professionals, outreach and qualifying nonprofit satellite organizations. It is jointly assigned with Ways and Means. Are they here? They're not here yet. But we're going to get started, right?
Sure. And Madam Chair, I believe two of our panelists are virtual, if that's okay.
Oh, absolutely. We'll call them as soon as you're done.
Thank you.
You're welcome.
And I appreciate it. I'm Delegate Stein's deputy, so I appreciate getting to go above him. And I will try to be brief because I did not bring my flak jacket with me. It's a pleasure to be in front of you all. For the record, Delegate Solomon here to present House Bill 859, which tries to get to the problem of something I know that you all in many different forms have been working on. is how do we get health insurance and access to health insurance for our workers, some of our workers who are doing some of the hardest jobs and may not see a whole lot of salary and may not see a whole lot of benefits. And so this is particularly for our child care professionals who are truly, we know, the workforce behind the workforce. And again, this is something I know that many of you have worked on for DSPs, for home healthcare aides, really critically important parts of our workforce that do unbelievably important jobs, and we don't pay them nearly or compensate them nearly enough for the work that they do. And so, I'm not going to get into the needs. You're going to hear from the experts here on the stats of the number of providers that we've lost and the impact on potentially what this could be for our state's economy. We've also made really incredible gains in childcare. We don't often talk enough about this, but through the work of the speaker, when she was just a mere regular member of the chamber, we really accelerated provider reimbursement rates. We've continued that trend through COVID, and we've gone from being actually one of the worst states in the country in terms of provider reimbursement rates to one of the best. And we've also seen, we think, the largest increase in childcare scholarship enrollment basically of any state in the country, from a COVID low of about 15,000 to now almost 45,000 children enrolled in child care scholarships. And for every child that gets a scholarship, that's a family that can go to work, that can go back to school, that can be productive members of our economy. So it's really wonderful. Not to mention, obviously, the benefits of high quality child care on a child's learning. So we're trying to get at the issue here of how do we keep those gains going, because if we don't support our providers, we don't support the workforce, we're not going to have the workforce to be able to continue to meet what we need, what we know is still only really a fraction of the needs in the state. And so this bill is trying to do that in two ways. And I'm not going to go too detailed in the minutia here because it is a little complicated, and I'm happy to follow up with the subcommittee folks on this. The first way that we tried to do this was by seeing if we could sort of open the state health insurance plan just a little bit of a crack to try to make a certain category of child care providers qualified nonprofits or qualified satellite entities as defined in state code. And you're going to see there's a letter of opposition from DBM because we have been going back and forth with them on this. So again, I won't get you into the details. I will just say we are not attempting to violate the law. We're actually changing state code, which already includes sort of a subcategory of essentially disability providers is a carve out. There's a carve out for legal service providers, and there's one other carve out I think that DBM talks about. And actually the last carve out was from 2003, where the previous iteration of DBM, I think it was the Department of Human Resources, was actually fully supportive of it. That was the one that opened it up for legal service organizations. And their opposition has to do with potential federal ruling about how many sort of non-government employees you can add onto your plan, even if they're a benefit to the state. And there's a ruling that says it's sort of de minimis, but de minimis is very vague. And so that was the back and forth that we've had with DBM. Suffice it to say, being on the state plan, even if you pick up all the costs, is actually tremendously expensive. We've also had a lot of back and forth over what that actual number is. It shouldn't really be that hard to get a number from our state agency on how much it costs to provide health insurance for state employees, but that's a separate issue. But it's very expensive, and even if we were to open it up, it would be such a small percentage of providers who would actually be able to even afford to pay the cost for state coverage for their own employees that we think it's still de minimis. So I wanted to at least highlight that. That is an issue I think that we need to work out more, but we wanted to put it in the bill as sort of a marker. The other piece of the bill, I think, frankly, for the more immediate term is a little bit more impactful. And what that would require is the Maryland Health Benefits Exchange to work with the Maryland State Department of Education, which has oversight and licensure requirements for all of our providers and has sort of the database of, they are the government point of contact for every licensed child care provider in the state, for them to work hand in glove with them through hubs that we set up in a piece of legislation last year that Chair Atterbury and I worked on, to essentially work hand in glove with child care providers to help them understand what resources are out there and how they can access them. So the bill is modeled off of best practices from the state of Louisiana and the state of Washington, where they really built sort of a very, very, very robust network of navigators to work with child care providers to help them figure out how you can access benefits on the exchange. If you qualify for Medicaid, how do you enroll? If you're designing a plan for your employees, what's the best way that you could do that might make it affordable? In a world where we had more budget resources, a lot of states that have tried to address this problem have just said, if you're a child care provider and you make below a certain amount, or you serve child care scholarship students, we're going to pay for your premiums. We're going to give you a category of health insurance for free through the exchange. Obviously, in tough budget times, we don't have anywhere near the amount of money to be able to do that. But at a bare minimum, we want to make sure that they know what's already existing. So the benefits exchange offered testimony that said we're sort of already kind of doing this, and we're happy to keep working with MSDE. MSDE said, this is sort of new to us. We don't really want to be a part of it. Again, the issue is we mandated that they set up these hubs, which are meant to sort of help providers pool resources, figure out how to do things on the back end that maybe if you're really great with kids, you don't necessarily know how to run a business. Those were established last year as part of a blueprint, and so we're working ongoing with MSDE to make sure that those are actually implemented. So the piece that's not in here, but I've been given permission to share this, is there is some money in the budget for some of the childcare pieces that we've been working on collectively, and so there's a possibility that we could move some of that money into more of a dedicated, maybe one-time expense to set up some sort of a system or a really intensive program over the course of the next year and a half, where it's not just we go to a conference and we give information, but maybe a set of navigators is literally going to as many childcare providers as they can and sitting down on site with staff or sitting down with providers and sort of working through it. So that's not in the bill, but we have the budget right now. There is money allocated from the governor's request for other sort of childcare related issues that we could potentially move around. But again, this was really to start the conversation, even if it was just baby steps, on what kind of creative ideas can we do in a universe where we don't have a ton of money to really provide, again, benefits and support for the folks in our workforce who are doing the most important jobs. And so with that, I would ask for a favorable report, and I'll turn it over to my panelists.
Who will go next?
I'm happy to. Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and honorable members. I'm Laura Wheeldryer, the Executive Director of Maryland Family Network, and I'm here in support of House Bill 859. You have my written testimony, so I'll be brief. A healthy child care workforce benefits families all over Maryland. Supporting access to benefits will provide desperately needed support for a struggling child care sector that is inarguably essential to the public good. The child care sector has not rebounded since the pandemic and is struggling both to retain their employees and to attract new people into the sector. Ensuring that child care professionals are aware of their potential eligibility for the Maryland Health Benefits Exchange or for Medicaid could support access to preventive care, decrease a caregiver's time away from children, and help manage their health-related expenses. To be clear, this is a nationwide problem. This is not just a Maryland problem. You already heard Delegate Solomon reference what some other states have done. We took a look at what the National Association for the Education of Young Children recommends when states are making policies trying to give healthcare access to child care providers. And their three tenets include ensuring that access is simple, easy, and widely available, ensuring the plan meets the child care provider's budget and health care needs, and ensures supports for transitioning staff who might lose Medicaid, getting them to other health insurance options and finding new coverage. The quality and sustainability of a child care program is directly and overwhelmingly determined by its staff. Supporting access to health insurance is a meaningful strategy to strengthen Maryland's child care workforce. I urge a favorable report on House Bill 859. Thank you.
Great. Yes, thank you to the sponsor and to the committee for the opportunity to testify in favor of House Bill 859. I'm Christina Push, Executive Director of the Maryland State Child Care Association. Child care is a public good and an economic and equity imperative. The child care workforce is passionate about the work they do. However, low compensation and lack of benefits are major sources of turnover. Turnover in the child care industry is high. It is a skilled, labor-intensive job for which workers receive low pay and limited or no benefits. For many, passion for the work alone is not enough to surmount the financial difficulties associated with the sector's low wages, and a lack of benefits and workplace supports are driving child care workers out of the field. House Bill 859 is an important step to health benefits and resources for the child care workforce. According to the Center for Law and Social Policy, and a recent analysis showed that just 20.7% of the child care workers have access to employee-sponsored health insurance, compared to 52.2% of workers across all sectors. Additionally, only 10.2% of child care workers had a pension or other retirement benefits. through their employer, whereas 35.0% of workers across all sectors. Our Maryland Comptroller in her State of the Economy series studied childcare in Maryland and its impact on the economy and labor participation rates. And she concluded childcare prices are high in large part because of provider costs are high. Childcare providers operate on tight profit margins, usually less than 1%. These margins do not allow small businesses to provide health care benefits. House Bill 859 will begin the steps to a shared service model for those critical benefits. House Bill 859 also builds on a hub model to support shared services and resources. The workforce is in decline, and we've lost over 1,200 programs since 2020. The time to act is now to support the early childhood education and care workforce through innovative, collaborative, and new initiatives and incentives outlined in House Bill 859. MSCCA urges a favorable report.
You have someone, is he not here? Christopher Cano?
Chris, yeah.
Here.
Oh, yeah, you can pull a chair up. Good afternoon. And please, if you will be so kind and move the microphone closer to you. Thank you very much.
Thank you, Madam Chair, honorable members of the committee. My name is Christopher Cano. I'm the Director of Political and Legislative Affairs for SCIU Local 500, which represents family child care workers here in the state of Maryland. You know, our members have a role in the lives of Marylanders from cradle to career, and this legislation takes a crucial step forward in providing health insurance for Maryland's child care professionals. You know, they play a vital role in the communities. They nurture and educate the youngest learners, and they enable parents to return to the workforce. Now, with the advent of the blueprint, we're looking at a mixed delivery model and thinking about the fact that these folks are providing public service, essentially, to our youngest learners. They're first teachers, if you will. And so the fact is that the bill goes a long way in allowing folks to participate in the state employee and retiree health and welfare benefits program as a satellite organization. But providing affordable health insurance is not just a moral imperative, it's an economic necessity. The child care industry, as you've heard, is facing a workforce crisis. And with many providers leaving the profession due to financial insecurity, access to health insurance will help attract and retain qualified professionals to work in these child care homes, ensuring that Maryland families have access to high quality care and ensuring that our economy continues to function as it does, especially in the wake of still recovering from COVID and the uncertainties that we're seeing with the federal government's instability. This is just good public policy, and thank you to Delegate Ms. Solomon for leading on this issue. I see the rest of our time.
Thank you for being here. We appreciate it. And everyone, thank you for your patience. I'm going to go to the virtual witnesses, and we have quite a few. So we're going to start with Ms. Daniels. Will you be so kind and you can get started with your testimony?
Yes, good afternoon.
Good afternoon.
My name's Ruby Daniels, and I'm a family child care provider and the president of the Maryland State Family Child Care Association, representing thousands of providers who are the backbone of early childhood education in Maryland. I'm here today in strong support of House Bill 859, which would finally grant family child care providers access to affordable health insurance, a necessity, not a luxury. Family child care providers meet the same high-quality standards as other pre-K educators, yet we are excluded from the benefits that sustain the workforce. Unlike public school teachers or some center-based staff, we operate independently, caring for and educating young children in our homes without employer-sponsored health insurance, paid leave, or retirement options. This lack of coverage puts many of us in an impossible position, choosing between our health and our livelihood. The reality is stark. Too many family child care providers delay medical care, they skip preventative treatments, or leave the profession entirely because they cannot afford coverage. When providers are forced out, families lose access to stable, high-quality child care, worsening an already critical shortage of early learning opportunities across the state. This bill is a common sense solution, allowing childcare professionals to receive government funding to buy into the state employee health plan as a supplemental organization. It recognizes that we are an essential part of Maryland's education system and deserve the same access to health benefits as our peers. Strong early childhood education starts with strong, healthy educators. By passing House Bill 859, you are investing in the well-being of providers, the stability of our child care system, and the future of Maryland's children. I urge you to support this bill. Thank you so much for your time and consideration. Thank you.
With us and for the work that you do. May we go next to Ms. Jeremy? I don't know if I pronounced it correctly. I apologize if I did not.
That's fine. Thank you so much. Yes, good afternoon. My name is Laura Jerome, and I serve as the Manager of Strategic Initiatives for the Montgomery County Children's Opportunity Alliance, which is a locally legislated early care and education coordinating entity that connects our community to build an equitable, accessible, high quality, and sustainable early childhood system. Thank you, Delegate Solomon, for your sponsorship of this important legislation, and to the committee for considering it. The early care and education workforce is critical in our community. They are, as Delegate Solomon said, the workforce behind the workforce, caring for young children so parents can participate in the labor force. And they are also providing critical education during the time when 90% of brain development occurs, laying the foundation for all future learning, behavior, and health. The childcare industry is a fundamentally flawed business model. The true cost of providing quality services costs more than parents are able to pay for it, therefore resulting in extremely low wages for early childhood educators, constant stress and turnover in the industry, and ultimately more difficult access for parents. When I say low wages, I mean that early childhood educators, on average, make less than 98% of other jobs in the state of Maryland. In Montgomery County, disparity is particularly pronounced. The average annual salary of childcare professionals in our county is $32,631, compared to the average salary of an MCPS school teacher at $86,686. The Comptroller's recent report showed that Maryland lost 26% of our workforce during the pandemic, and we haven't recovered. The childcare industry in our community continues to lose early childhood educators to the school system and to Washington, D.C., which pays higher wages and better benefits. Providing more equitable benefits will help recruit more educators into the profession. Montgomery County has over 1,200 independent childcare providers, the majority of which are small businesses and nonprofits, and they have to make hard financial decisions every day. We respectfully urge the committee to make a favorable report on this bill, as it will improve the sustainability and quality of early care and education professionals. Thank you.
Very much. I believe next is Ms. Schaefer, Stephanie Schaefer. Good afternoon.
Good afternoon. My name is Dr. Stephanie Schaefer. I'm the program coordinator for the Maryland Association for the Education of Young Children. I'm here today to testify in support of House Bill 859. I certainly want to thank the chair, the vice chair, and the committee for the opportunity to speak with you today and for hearing this bill. The Maryland Association for the Education of Young Children is a professional association of over 1,700 early childhood educators throughout the state and other allied professionals and families. We promote high-quality early learning for all children birth through age 8. Having health insurance is essential to accessing affordable medical care. Child care professionals are better able to care for the children they serve when they themselves are healthy. Like other workers with low incomes, child care workers often work for small businesses or self-employed in family child care homes and lack access to affordable coverage options. I have seen child care workers who avoid seeking medical care for illnesses or for chronic conditions because they lack affordable health coverage. The costs are too high for them. So we appreciate the leadership of Delegate Solomon and Delegates Guyton, Jones, and McCaskill for their work to help child care professionals access medical insurance coverage. Having health insurance would help more child care professionals get the medical care they need to stay healthy so they can continue to do the important work of providing care and education for Maryland's young children. For these reasons, we respectfully urge the committee to return a favorable report on House Bill 859. Thank you.
We appreciate it. Let's go to Ruth Carolina Reyes.
Yes, good afternoon. Buenas tardes.
Good afternoon. Buenas
My name
tardes.
is Carolina Reyes, and I am the owner and director of Arco Iris Bilingual Children's Center. I currently employ 8 dedicated teachers who work tirelessly to provide quality early childhood education. Childcare providers across the nation constantly struggle with a lack of health insurance, and my teachers are no exception. The demands of their job, physically, mentally, and emotionally, are significant. Yet, many do not have access to the healthcare they need and deserve. Personally, I am fortunate to have the health insurance through my husband's job. Without it, my family will struggle. Just like many childcare teachers who may not have a spouse or a partner to provide coverage. The cost of health insurance is extremely high, and as a small business, I cannot afford to provide this essential benefit to my employees. Every day, childcare teachers are exposed to illnesses, endure physical strain, and navigate emotional and mental challenges of their work. Ensuring their access to healthcare is not just an investment in their well-being, it's an investment in the future of our children and communities. I urge you to support legislation that will grant childcare professionals access to affordable health care. This is a necessary step towards recognizing their invaluable contribution and securing the sustainability of early childhood education. Thank you for your time and your support.
Thank you. We have one more. You can go ahead and give us your testimony. Ma'am, will you be so kind and give us your testimony? Can you hear us?
The
Yes.
name, please?
My name is Jocelyn Peña-Milnick. Your name is Rashmi?
Yes.
Who you,
Hi, how
can you
doing?
give us your testimony, please?
Yes, now I can hear you. Ms. Breslauer.
Yes.
Hi, how are you doing, guys? I am a family childcare provider in Columbia, Howard County also. And we are the foundation of the kids, young generations, and giving them the very strong foundations and values and everything, and opening our hearts, houses, and arms to be welcome them over here, to protect them and giving them the good foundations. Because of the health insurances and everything is very challenged to be work with in this field, because especially we are not having any benefits or anything from anywhere. We being self-employed, and the COVID time, only the family child care was the open who faced for each and everything to suffer with these families. And we put our families into those kind of situation where we welcome these little hearts to our hearts. So I really appreciate, thank you to let me speak. I really appreciate if we can consider to the health insurances and all those for the family child care providers and go to the good way. Thank you very much. I really appreciate if you guys consider in that and let me speak. Appreciate.
Appreciate the work you do in Maryland. I'm going to open it up for questions now. Are there any questions for the sponsor and his panelists? I saw Delegate Johnson first.
Thank you, Madam Chair,
My
and thank
pleasure.
you, Delegate, for bringing this bill. So I'm looking here, and it says child care professionals to participate in the program as a satellite organization. But then I'm looking in the fiscal note, and it says the Department of Budget and Management advises that child care providers are not likely eligible to participate as a satellite organization. So could you clear that up a little bit for us?
Yeah, thanks for the question, Delegate. That's sort of what I was trying to get at before. So I think there's a little bit of it's a misquote. So if we add an additional threshold to the satellite or an additional category to the satellite organizations, that's our legal prerogative to do that, and that's what the bill does. What I think they're conflating is DBM's concern that, again, we're still sort of working through, is that so we could say we add all the satellite organizations we want. Let's say, like the state of Connecticut, for example, tried to add all of their healthcare providers, their nonprofit healthcare providers, onto their state plan, and it would like literally have doubled the number of people eligible for it. And so they went to the U.S. Department of Labor, which has certification over whether these plans are government-sponsored plans or not, and the USDOL, I think this was back in 2012, said, no, that's way too many, right? If you wanted to add maybe like 100 or 200 or 300 for a specific reason, that would probably be okay. And so DBM's concern is that even if we add a tiny bit more, they're looking at the sky is going to fall. And so I think that didn't necessarily get translated properly to DLS. We're legally allowed to add whoever we want to this plan. It would then be DBM's, as the plan administrator, their responsibility to go to the U.S. Department of Labor and make sure that everything that we've added to the plan still meets the federal requirements for a government-sponsored plan. Otherwise, these now become taxable benefits.
All right, thank you for clearing that up. Thank you, Madam Chair.
Yeah, thank you for the question.
You're welcome. Are there any other questions for the sponsor and his panelists? I know that you stated that you're working with all the different parties, and thank you for doing that. The committee really, it makes our life a lot easier. And I want to know the issue of the program's pre-tax payment, that you're addressing that with DBM. I know you said, is that something you think you can
that to be determined.
Yeah.
We're working with the Speaker's office on it as well. Again, it may be ultimately something where, because we were operating under an assumption, to be quite honest, that our state plan was much more affordable than we thought it was. And then we got some information from DBM very recently that questioned the numbers that had been presented to us through DLS and DBM earlier. And so the cost of the plan becomes so expensive, and you all will appreciate this because it is an ACA eligible plan. You also have to meet the affordability index that the federal government lays out, so you have very limited abilities to change the share in which what the employer share would be versus the employee share. So even if we were able to do this again, and that's one of the frustrating things with DBM, is there is probably only a handful of larger nonprofit providers who would actually be able to even make this work. So I think the more important focus is probably on getting things right with the benefits exchange and MSDE, on actually doing the outreach, the really targeted outreach with providers to help them access the resources that we've got already.
That makes sense. Okay. Delegate Bandari.
Thank you, Madam Chair. Thank you for addressing that pre-tax benefit issues. So I'm wondering, one of the alternative could be expanding existing small business health insurance program. That's number one. And number two, a separate health insurance subsidy or premium assistance program to help them out. Did you consider those routes?
Yeah, Delegate, I mean, that's a great question, and those would be things, I mean, again, when you're sort of looking at best practices at other states, we already do actually a lot of them. It's like expand Medicaid coverage, really lean into your programs, which, again, at the wonderful folks in this room, we've done a lot of that work, but to your immediate question, that stuff all costs a lot of money. We would love to, I mean, if we could say, home health care aides or child care workers, if your income is below a certain amount, or if it's beyond that threshold, just by working in these fields, you would get, let's say a gold level plan in a lot of states is what they say will cover everything. That's what they do in the District of Columbia, our nearest neighbor. We just don't have the money for it. Again, this to me was baby steps until potentially our budget is in a little bit of a better place. One of the other bills I've put in, and that's going to be in Ways and Means, is a broader creation of an affordability commission for childcare. Again, I talked a lot about the gains that we've made. One of the big cuts in the budget that the governor has proposed is to cap and move backwards on some of our childcare pieces. So the commission would hopefully look at robustly with the business community, with partners from childcare, with labor, really what do we need? What kind of revenue, what kind of long-term sustainable revenue do we need to make our childcare community successful? And one of the pieces in there would be a broader look at benefits. But again, with the budget, we're not in the place this year to do something like that. If you can find money, it'd be great. I was going to say, yeah, that's my responsibility in appropriations, yeah.
Appropriations. Any other questions? All right. Seeing none, thank you very much, Delegate, for your hard work, okay? And if you can work those issues out and let the committee, let us know so that then we can send it to subcommittee, okay?
Absolutely.
When you think it will be ready.
Yeah.
All right?
Thank you very much.
My pleasure. We do have one more witness for this bill, and it's an info. Robin Rice. It says in-person oral. Is Ms. Rice here? Good afternoon.
Yes, this bill is cross-filed with Senator King, who is our child care champion, so anything she wants is fine with me. Delegate Solomon has his pulse on the childcare community, so again, support whatever he wants. Delegate McCaskill has House Bill 477 introduced. We need that bill desperately. That bill can do more for the childcare profession than anything else you can do in this session. MSDE, however, I'm concerned about them getting more responsibility because they don't comply with the laws, they don't comply with the regulations, they make up regulations without writing them down. There's also severe abuse of power from the Office of Child Care. One provider's losing her house, a church was closed, somebody lost their Excel rating, somebody lost their insurance. There's also incompetence. The credential program required providers to work for a year doing extra training and to do professional activity units. And within 30 days of their anniversary, they were told they were not going to get paid. That's a breach of contract. The voucher system is a paperwork nightmare, and providers are not going to accept them anymore, especially no infants. They'll only accept them if they have to. One of the problems of getting medical insurance and doctor's appointments is family daycare providers are prohibited by the regulations from getting a substitute for more than 20 days a year. You have to close your business to go to the doctor. If a family daycare provider wants to hire me, I'm fully qualified, 40 years experience at the top level, credentialed at the top level. I have to get my fingerprints done 1,200 times to be able to walk into any place and help them as a substitute.
I'm going to open it up for questions. Are there any questions? Vice Chair Collison?
Thank you, Madam Chair. I just want to follow up on that last comment, Mrs. Rice. So literally you're saying you would have to be fingerprinted under the direction of MSDE for every single provider that you could substitute in?
Yes, ma'am.
Thank you.
And if you go and help somebody without it, the facility that asks you to help will get a non-compliance, which means they'll lose their cells and their insurance.
And your original fingerprints are held in MSDE, is that correct?
They're held with MSDE and the business, so they're both of them.
But they are in MSDE?
They are in MSDE. We are cleared. All right. Okay. So if I wanted to open up a business saying, okay, I'm going to try to find all the retired people that would like to help out for a day or two and let them go to any of these, 1,200 facilities in Montgomery County, I would, again, have to have all of those people done 1,200 times from Montgomery County.
Thank you for that information. I appreciate it.
Yes, ma'am.
Thank you. Any other questions? Seeing none, thank you so much for being with us.
You're welcome.
This actually concludes the bill hearing on House Bill 859. Thank you, Delegate, for being with us, and keep us posted on your progress. We are now going to turn over to the Speaker Pro Temp's bill, which is House Bill 938, Continuing Care Providers Governing Bodies Membership. Will you be so kind and bring your panel, please?
Yes, thank you, Madam Chair.
Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members. This bill deals with the governing bodies of continuing care retirement communities. Their acronym is CCRCs, and a CCRC is a type of retirement community where its older residents can receive a continuum of care. And before I explain what the bill does, I want to thank the Vice Chair for her work in bringing the residents and the providers together to forge this compromise bill, which both the residents and the providers are good with. So thank you, Madam Vice Chair, for your help on that. Current law says that if a provider has a governing body, at least one of the provider subscribers or residents has to be a full and regular member of the governing body. And the idea behind this is that CCRC residents are the primary stakeholders of a CCRC and have the greatest risk of, greatest financial risk of these enterprises. And so it's only appropriate that they have the opportunity to participate in as a member of the governing body. And so the bill says that if the governing body has just one subscriber, then an alternate subscriber shall be appointed to the governing board. The alternate subscriber may attend all meetings of the governing body, but can vote only if the regular subscriber is unable to fulfill the subscriber's duties as a regular member. So this is important because residents of CCRC tend to be older and, frequently not in the best of health. And so a resident who's the regular member of a board may not be able to attend meetings of the governing body, at least from time to time. So having an alternate will ensure that residents can have a voting presence. It will also provide another resident voice on the governing body. And I do want to mention, and the providers will discuss this, they will discuss an amendment which extends the effective date by 3 months to January 1st, 2026, which we are fine with. And with that, I urge a favorable report.
Madam Chair, members of the committee, Barbara Brocato, here in support of House Bill 938, and on behalf of the Maryland Continuing Care Residents Association. As Delegate Stein has said, this assures that there's one voting resident on the governing board. I just want to spend a little of my time to say that continuing care retirement communities are entities where the residents really do absorb most of the financial risk. They pay substantial deposits, they pay substantial monthly fees that can range from 2% to 18%, depending on what the plans of the community are and where the community is. So they have that vested financial interest as well as making the decision that these communities be their home for their life. Over the years, and I've represented them since 1994, over the years we've developed a body of law. And it's important to realize that there are 3 types of communities. The earlier communities, which are called a type A, actuarially, they have amortized the cost of all levels of care, independent, assisted, and nursing care. And you don't pay more as you need more care. The more recent type of the communities and the larger communities that have been more recently developed are type Cs, and they are fee-for-service communities that they're not amortized. You need a higher level of care, you pay out of pocket. So there's a lot of distinction there. I would just want to say that over the years, I remember the onset when Senator Bromwell, back in '93, heard testimony from the providers, John Erickson at the time on one side and the residents on the other side. And Senator Bromwell at that time saw somebody in the Department of Aging at the back of the room and said, bring people together. Since then, previous administrations have brought together all the parties to sit down and discuss things. And I have to thank the chair, the vice chair, the subcommittee chair, and the sponsor on their efforts to bring the parties together on this compromise bill. Thank you so much.
Thank you. Before I open it up for questions, I do want to thank my vice chair. I know that I give her all the difficult bills that I don't want to take, just kidding. And a lot of you, when I ask you in the interim, can you be on a work group, this is the result, right? You work on it. I feel that a lot can be done without, bills, and that we can have meetings and try to work it out. So I want to thank everyone involved as well. And thank you to the sponsor, Speaker Pro Temp, for your willingness to work with the committee. I'm going to open it up for questions now. Are there any questions for the sponsor and his panel? All right. Beautiful. Thank you. And thank you for everyone, all the advocates that came together as well. I'm going to call Allison Cyborowski, Donna Kaufman, Bruce. Actually, will you be so kind and pull up the virtual witnesses as well? Bruce Harton and Dan Tracy. And good afternoon. You can get started. And thank you all for working with the sponsor.
Yes, thank you, Madam Chair, Madam Vice Chair. My name is Allison Siborowski, here today on behalf of Leading Age Maryland, and we are here in support of House Bill 938. I want to just echo thanks for Vice Chair Cullison bringing the stakeholders together, and to Delegate Stein for his leadership as well. So Leading Age Maryland represents the vast majority of CCRCs in the state, and we feel that the provision requiring the governing body to include an alternate subscriber will ensure that the subscriber, the resident's voice, is consistently represented. So thank you again to the sponsor and the committee for its ongoing willingness to work with us. Thank you. Oh, I also just wanted to echo the amendment to extend the effective date to January 1, 2026. That's important because all of these organizations will have to amend their bylaws and identify this alternate board member, which doesn't happen overnight. So we appreciate the extension till January 1.
Hey.
Madam Chair, Madam Vice Chair, members of the committee, for the record, Dana Kaufman. We are in support of House Bill 938 with the amendment that my colleague just mentioned. I will not belabor. We appreciate the work group that was formed to talk about this issue, and we believe that it resolves the issue and it provides the residents with the continuity of information that they were searching for. So thank you.
I love it. Nice and short. Very nice. Let's go actually to the virtual witnesses. Go ahead, Mr. Harton. Will you be so kind and get started?
Thank you for the opportunity to speak in support of House Bill 938. Good afternoon.
Good afternoon.
Bruce Hartung, President of the Maryland Continuing Care Residents Association. To start off, how would you like giving, say, $100,000 or $1 million to someone you did not know, but came recommended to you, and then you said to them, keep it safe, use it well? That's exactly the situation of CCRC residents, except that their expectation is that the money would be used wisely and focused on the provision of your experience of your life for the remaining years of your life. If you were in that situation, would you not wish some way to influence the use of the money, or at least see that it was used in a way that was responsible and supportive of living conditions that you were in, and to have ongoing confidence in the financial soundness of the organization? This bill requires a bit more involvement of CCRC residents in governance of CCRC communities, because it requires a second board member on the governance group of the community. It goes a long way to ensure a resident presence, as only one board member could become ill or incapacitated. It fosters collegiality and mutual support, working against the isolation of a single board member, and generally makes very good sense. As far as I know, this bill is supported by enlightened providers and owners, as well as CCRC residents, and so I strongly urge a positive response to this bill and thank everyone who came together in order to make it happen.
Thank you for your advocacy, sir. We really appreciate it. I'm going to open it up for questions for these panelists. Are there any questions? Seeing none, thank you so much, and thank you for working it out. And I believe that we have one more person.
Yes,
Dan Tracy? Yes, hi.
Yes, I'm Dan Tracy, a resident of the Mercy Bridge Retirement Community in Timonium, Maryland, and a vice president of MACRA. It's important that you understand that a continuing care retirement community, a CCRC as we call them, is a unique entity. It's not like other retirement communities because of the legal status of the residents. The residents are not shareholders, they're not nonprofit members, they're not secured lenders, they're not even tenants. So they have no voting rights in the operation of the community. And yet the residents are the primary stakeholders of the CCRC. They're the reason for the CCRC's existence. They've each made a substantial and financial investment in and commitment to the CCRC essentially for the rest of their lives. Indeed, as Delegate Stein and Ms. Bricado have noted, It is the residents who bear the primary financial risk of these enterprises. Now, CCRC governing boards understandably treat the CCRC as a business, and their decision-making is guided by the goal of having a successful business. But for residents, their CCRC is not simply a business, it's their home, more often than not for life. Since the residents are both the primary beneficiaries of the business and the stakeholders that bear the primary financial risk of the business, it is essential that the governing board have significant resident input in the ultimate decision-making process. Having 2 resident board members rather than 1 will double that input. 2 different perspectives on resident concerns and objectives to be considered by the board in making financial decisions which directly impact the residents more so than any other stakeholders. Thank you for your favorable consideration of this bill.
Thank you for your testimony, sir. We really appreciate your advocacy. Are there any questions for this witness? See none, you both have a blessed evening, okay? Thank you for being with us. This actually concludes the bill hearing on House Bill 938. Next, we're going to move on to House Bill 828, Delegate Kipke, Healthcare Facilities, Rights of Comprehensive and Extended Care Facility Residents, Hospice Comfort Care. Would you bring your panel up, please, if you have one?
Thank you, Madam Chair. Good afternoon, members of committee. Delegate Kipke presenting House Bill 828. I've introduced this legislation after learning about complications my friend and legislative assistant had during the time that her dad was recently in hospice, being treated with through hospice. What the bill seeks to do is to provide common sense tools to people at the end of life to provide them with comfort. This unfortunately sometimes doesn't occur when an individual is in hospice at an assisted living home. The reason for that is spelled out in the fiscal note that explains the Residents' Bill of Rights, which is a wise portion of the law that seeks to protect individuals from having their rights stripped away, for example. You know, for someone who's deemed to be difficult being overly sedated or tied down. Those things obviously are immoral, and we should protect against it. But because that's in the law, people that are in assisted living with hospice care, they're being prevented. They're not being allowed, in some instances, to have access to, for example, anti-anxiety medications, Valium, sleeping pills. For someone who's at the end of life being treated with hospice who are having constant falls, they're not allowed to have the bed rails used on the bed. At the request of the family, they wanted a certain type of chair so that he could sit in the chair to have comfort, but they wouldn't allow that type of chair. So what the bill seeks to do is create a carve-out in the rights of the residents for individuals under hospice care. I circulated this early on, as our chairman likes us to do, and I did receive feedback from the Mental Health Association of Maryland, who has offered amendment language that we support to protect against, this becoming something that people take advantage of. Fully support that. I want to thank Dana Kaufman, who's here with me today. She, as you know, is an expert in this area of law, and she has helped me develop an amendment which the committee has that, I'll let her explain it, but further clarifies where this should be in the law. There is opposition from the Maryland Legal Aid group. I don't know if I can solve their opposition, but I think we can certainly try. One of the issues that they raise is the bill speaks to prescribers and not to physician. I'm not sure if that's a necessary change, but it's definitely something that we can talk about. So, you know, this committee is very familiar with deeply emotional issues as it relates to end of life. And it's not always easy to provide for end of life care, as robust, the palliative, the hospice, whatever it may be. We want to do as much as we possibly can do to ensure that our loved ones and ultimately us are giving all the comforts that we need and I think most people would expect at the end of life. So I offer this bill as a way of expanding access to quality hospice care for individuals while they are in assisted living. And with that, I ask for favorable consideration of the bill with amendments. Thank you.
So much. Next, please.
Madam Chair, Madam Vice Chair, members of the committee, Dana Kaufman, again here on behalf of Lifespan Network. So there is a very delicate balance when we are addressing the use of chemical and physical restraints. The one thing I will say about the bill as it was initially put in, it was put in subtitle 3 of Title 19. That is nursing homes typically. So the first thing that the amendment does is put it in the assisted living section, which is subtitle 18. And then it basically kind of mirrors the rest, the original bill. As you know, assisted living, most of the requirements are in regulation and the legislation or the code provides the framework. The issue is when somebody is in a hospice program in assisted living, it is supposed to be the hospice program that decides the care. They step in and they take over the daily care and the treatment plan for that individual. But at the same time, we do have a situation where our regs are very specific about the use of chemical and physical restraints as well as protective devices. And what oftentimes happens is there is an inconsistency because we do have a concern, the assisted living providers, that when a restraint that would normally be not ordered by, when it's not a hospice resident and it's being used in the general population of assisted living, it's seen as a restraint and it can be subject to deficiencies and it can be very subjective about, whether or not that's appropriate use of it. So what we're trying to do is really mark off and make a distinction between individuals who are in assisted living, but individuals who are in assisted living, but their care is being provided by hospice. So it's the hospice rules and the ordering that takes precedent, and it does then give some flexibility for the assisted living providers.
Thank you. I'm going to open it up for questions now. Vice Chair Collison.
Thank you, Madam Chair. And Dana, you have a lot of experience in these facilities, and thank you, Delegate, for this bill. The health department says they're worried about confusion for the reason you just said, because you've got sort of two different codes looking at one person. In your opinion and your experience, do you think that confusion can be overcome in those settings?
I personally think it can be overcome because, again, when an individual is even though they're in assisted living, their care when they are admitted into hospice, and as you know, hospice is a federal program. Mm-hmm. So the rules are much different. So as long as that treatment plan now becomes basically the property of the hospice program, I think that's the definitive change. And we need to make sure that if it is a restraint being ordered, is it being ordered and is that patient a hospice program recipient at this point?
So there is already a distinction.
Yes, there should be a distinction. And the regulations right now does make a distinction. So there's a difference between an individual who is in assisted living and goes to hospice, why they are in assisted living, let's say, and then there's an issue and the regulations make this exception, there are certain conditions where you are not allowed to be admitted into an assisted living program. For example, if you need more than intermittent nursing care, treatment of stage 3 or stage 4 skin ulcers, ventilator services, you're not allowed to be admitted into an assisted living unless you are under treatment of a licensed general hospice care program, because then you can be admitted into assisted living because that assisted living is basically serving as your room and board, but your treatment is being done and cared for by that hospice program.
Great. Thank you, Madam Chair. Thank you.
Delegate Bagnall? Your question was, okay, Delegate Hill.
Thank you, Madam Chair, and thank you for the bill. I just want to give you a chance to respond to Maryland Legal Aid. You've read that. Now, I don't know, have their concerns been addressed? You mentioned the issue of provider versus, or prescriber versus physician. I'm not clear that all of their issues have been addressed.
So, unfortunately, I did not look at that. I didn't see it, so I'm happy to take a look at it and respond back to you. I will say in the amendment that was drafted, it was drafted to say ordered by, that the restraint was ordered by the licensed general hospice care program. So I didn't do it in a way that says, prescriber or provider, meaning an individual, but the licensed hospice care program. But again, I'm more than happy to take a look and talk with them to see if we can address their concerns.
Okay, all right, thank you.
Okay. Delegate Guzman.
Thank you, Madam Chair. Having just walked down this road myself within the last month, I would also just want to put in a little bit of a plug, and I don't know how this works, with regard to ensuring that family members who are impacted by this really get a full understanding of what it means to be moved into hospice, what kind of hospice you're in. Does that make the primary care doctor not really effective anymore, sort of part of the process anymore, all that kind of stuff. So I don't know that it fits under the legislation, but just wanted to wave the flag for family members who are making these challenging decisions.
Something's in the air. Johnson? All right.
Thank you, Madam Chair.
Trying to find you, Steve.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill, and Ms. Kaufman for helping work out the amendment. I was a previous owner of a pharmacy, and we were the only pharmacy in the community that worked with the hospice folks. And at the end, when you're in hospice care, it is those folks who are giving you most all of your direct care and dealing with the patients. So I like the fact that you're putting the decisions more into people's hands that are working with the patients. And I wanted to ask the sponsor if you would be open to making this an emergency bill and moving the date up. Because usually when you're in hospice, there's not that much time. So if we could get more patients the care they need in a quicker frame of time, I think we should do that.
Thank you. I appreciate that. I think we just need to figure out some language that addresses the issue brought up by Maryland Legal Aid and the Mental Health Coalition, just to make sure that the language is in perfect tone to protect against a bad actor who would take advantage of this. I can't imagine it happening, but crazy things happen, and I agree with their concern. But I don't think it should prevent us from moving forward with something that also provides necessary comfort care at the end of life. I'll note in the Department of Health's testimony, they cite some language in the federal code that seems pretty intuitive as it relates to this, where if restraints are being used for the least amount time necessary, free of any coercion, disciplining, for the convenience of, there's some good language out there. I think we just need to find it and get that adopted, and I certainly would support making it an emergency bill. Thank you.
Thank you. Thank you, Madam Chair.
And thank you for allowing me to come back. I'm sorry, Ms. Kaufman, can you just clarify, since hospice can be in a hospice facility, it can be in a hospital, it can be at home, the current regulations that prohibit the use of safety restraints, et cetera, and chemicals, does that also apply to home hospice? And if so, will this bill also address allowing people to be safely restrained or restrained for safety purposes in these cases?
So I think one of the issues when Lifespan looked at the bill is that, again, if you're in an assisted living program, there are very stringent requirements for the use of chemical and physical restraints. Not that they cannot be used, but you have to meet very specific requirements, and they also have to be renewed every 7 days. So it's not something that can be ongoing or on an as-needed basis. So what we were trying to do is make sure that there was a divide between those requirements for individuals who were not in a hospice program, but those in a hospice program. And I'll have to be honest, I'll have to go back, as Delegate Kipke said, and really look at the guidelines for when restraints are in hospice or for a hospice patient, but I do believe that they would go across the board. But I was looking at it because I know some of the issues that have come up is this kind of struggle between the two programs, between hospice and assisted living, where even though the resident was under the care of hospice, the assisted living was very concerned about using restraints because of their regulation and ending up getting a deficiency because of something that was happening and ordered by the hospice program. So we don't want to have that kind of struggle between the two programs. So we were trying to, in this amendment, make it a cleaner division, basically. But I will go back and double check the hospice regulations.
Right, so you were not addressing at all home hospice, but you'll see if that accidentally gets pulled in inadvertently or should be pulled in.
Yeah, it won't be pulled in here because this is only in the assisted living statute.
Okay.
Bandari.
Oh, thank you, Madam Chair. This wonderful bill, in the light of the conflict with the federal regulation, I could suggest, to make this bill more safe. If we clarify that restaurant may only be used as a last resort and must comply with the federal regulation or guideline, if you could mention that. And I don't know the current law, if we could make a written consent from both physician and the patient or legal guardian before restaurant can be applied. That could be another solution. And last could be mandate a review or reporting process to prevent and discontinue the restaurant as soon as it is not medically necessary.
Thank you, Delegate. It's my hope that our chair will have this reviewed in subcommittee, and your suggestions, I think, are good, and there's some other suggestions here that I think we just need to fine-tune. Thank you.
Any other questions? Okay, I know we have the Maryland Legal Aid next. I think I would like to suggest the Maryland Legal Aid. Would you please come up, Gloria Brown? Ms. Gloria Brown, and the sponsor of the bill, and Ms. Kaufman, Ms. Hill, and Mr. Bandari, if you could form a little subgroup and try to work on the language. As soon as you have it ready, we could put it in subcommittee. All right, go ahead, Ms. Brown. Can you give us your testimony, please? And good afternoon.
Good afternoon. I'm Maria Brown, and I'm a staff attorney at Maryland Legal Aid. Thank you for allowing me to testify in opposition to House Bill 828. Each year, our office assists hundreds of Maryland residents in forced medication and Office of Health Care quality matters involving allegations of neglect and abuse. Some of these clients have and will continue to be hospice patients. It is therefore with a heavy heart that we testify in opposition to House Bill 828, which expands the list of individuals, at least as it was originally written, who may prescribe chemical and physical restraints in these end-of-life moments. Importantly, our clients have the right to remain free from restraints as a matter of law, and only in the instance of clear medical need may providers order restraints. Nonetheless, we know that abuse and neglect can occur. Imagine a homeless individual with his closest relatives in another state. His legal and physical guardians, who have no direct in-person contact with our client, place him in an assisted living facility. His health declines to the point that he enters a hospice program while still residing in the assisted living facility. At one point, he is medicated, a form of chemical restraint covered by the bill. He is left to lay in a public area, unresponsive, and unable to protect either himself or his dignity from the other residents who mill around him. This is the situation in which one of Maryland Legal Aid's former clients found himself. The present statutory restriction of physician-only power to order restraints guarantees that the most intensely trained individual on the hospice patient's medical team, the medical doctor, can weigh the genuine need for the restraint from solely the patient's viewpoint as is ethically required. The physician will also best tailor how such restraints may be used, hopefully in the event of an individual living in a public shelter, guaranteeing that the patient is not overly medicated with any drug, whether an anti-anxiety drug or an antipsychotic, to the point he can protect neither himself nor his dignity. With deepest respect for the non-prescribing medical providers on a hospice patient's team, Maryland Legal Aid maintains its opposition to HB 828.
Thank you. And I know that you're testifying in opposition, and I thank you for the work you do, because you do God's work. I know it personally. I'd like for you to please make yourself available to work with a small subgroup to try to find language that is acceptable and that works, okay?
Thank you.
My pleasure. Are there any questions for this witness? And you're welcome anytime. Thank you so much, okay?
Thank you.
You're welcome. Delegate Kipke, do you have her information?
Yes.
Oh, you do? Okay, so they'll be in touch with you, okay? And thank you for being willing to work with us.
Thank you.
Appreciate you. This actually concludes the bill hearing on House Bill 828. We are going to move on now to House Bill 933. Delegate Martinez. Is he in the back? Do we know? Yes, please. Thank you. Oh, okay. All right. And this is nursing homes, direct care wages and benefits and cost reports. Will you be so kind and bring your sponsor panel? I believe is Claudia Baglag, Ryan Moran, the acting Secretary of Health, Ryan Moran, Sam Williamson, Chris Myers, and Holly Ward. Will you be so kind and come up, and you can bring a chair if there aren't enough chairs up there. I'm sure the delegate would appreciate the company.
Oh,
Go ahead.
absolutely. You can't do anything alone.
Nope. And for the committee, we're doing well, moving right along. Thank
right.
you for your patience. Everyone else is waiting. You can get started.
Well, thank you so much, Madam Chair, Madam Vice Chair, and HGO colleagues. For the record, I am Delegate Ashanti Martinez, here to present House Bill 933, the Nursing Homes Direct Care Wages and Benefits and Cost Reports. You might remember this bill because it's a reintroduction from last year. 66% of nursing home industry's $140 billion total annual revenues comes from public programs, primarily Medicaid and Medicare. While billions of dollars are being funneled to increase nursing home profit, there is very little oversight of this spending. This legislation aims to ensure responsible oversight of how nursing homes spend their money to protect the care of our most vulnerable. By requiring that nursing homes submit an annual cost report to the Maryland Department of Health. This bill also establishes that nursing homes allocate a specific percentage of their total revenue towards direct care and wages and benefits. All of these measures are done to improve nursing home physical transparency in an effort to increase quality care. Included is an amendment to this bill that I'm presenting to eliminate the mandate that would require 75% of a nursing home's revenue from nursing and residential sources be spent on wages and benefits. In turn, the Maryland Department of Health would be in charge of oversight and analyzing for the cost reports, as well as the staffing of those cost reports. With these amendments, no additional staff will be needed to be hired from the Department of Health, eliminating the physical responsibilities that would be generated otherwise. It is time we compensate our caregivers for the valuable work that they do each day. The demand on caregiving has grown, the concept has broadened, and affects both life and work really intensely. Today, you will hear from a panel that includes various stakeholders of the nursing home and healthcare industry, namely workers and patient representative groups that will speak to the importance of bolstering jobs and care in Maryland's nursing homes. House Bill 933 is supported by AARP, Public Justice Center, Anne Arundel County Commission of Women, the Maryland Continuing Care Residents Association, Maryland Legislative Agenda for Women, AFL-CIO, Marylanders for Patient Rights, Public Justice Center, National Women's Law Center, and the Maryland Department of Health now that the bill is amended. This legislation helps to ensure that our caregivers receive the compensation and the support they deserve. I strongly urge a favorable report on House Bill 933. You can just go. Please.
Madam Chair, Madam Vice Chair, members of the committee, thank you for this opportunity to testify in favor of HB 933 with the sponsors' amendments. My name is Claudia Balog. I'm the Assistant Director of Research for 1199 SEIU. We've supported legislation before this committee for a number of years to raise Medicaid reimbursement rates for providers while mandating that a portion of those rate increases are passed through to workers. Even without the budget crisis that we face right now, 1199 takes the view that a good approach to the workforce problem would be to mandate that a percentage of nursing home revenues are directed to worker wages. I've reviewed cost reports from many facilities and chains. There are nursing homes in the state dedicated to providing quality care and addressing short staffing. Unfortunately, there are others, some acquired by private equity or similarly structured ownership entities where the numbers tell a different story. In these facilities, someone is profiting at the expense of resident care. I've seen cost reports filed by facilities where operators pay increasing amounts of money towards rent expenses each year, but to building owners who also have an ownership stake in the nursing home. These complicated business structures make it easier for individuals to profit off of residents, and they allow for owners to make decisions that don't put quality at the top of the priority list. If we're going to address the staffing shortage, we have to understand how nursing homes are allocating their revenues. HHS found nursing homes paying 40% of their revenues to related parties. Finally, I'd like to note an example in Massachusetts, where by regulation, 75% of a skilled nursing facility's revenue has to be allocated to direct care. Nearly 80% of the nursing homes in that state meet or exceed that threshold. The analysis that's called for in this bill, identifying where dollars are being allocated, will allow Maryland to set our own direct care spending floor. So thank you for your favorable consideration of this bill.
My name is Holly Ward. I am a geriatric nursing assistant in a long-term care facility and a member of 1199. I support House Bill 933, the Nursing Home Care Crisis Transparency Act, so the state can have more oversight on how nursing homes spend the public dollars they are allocated, dollars that are meant for resident care and worker wages benefits. Low wages mean higher turnover, and staffing crisis in long-term care is unable to keep workers. What will older adults and people with disabilities do to survive? Long-term care is important because no one foresees that they will need this kind of assistance. The residents do not choose to be there. I love my job because I provide them with empathy and compassion. We need legislators to realize that as medical providers, we put most of our lives into these residents. It is shameful that we are paid such low wages after all the sacrifices that we make. Our care team is burnt out with overwhelming workloads, dangerous staffing shortages, and emotional toll of caring for residents facing isolation, sickness, and death. We do not receive the respect that we deserve when these facilities would not run without us. Low pay requires me to subsidize my income and rely on assistance such as food stamps. Transparency about how nursing home management allocates their money is good public health policy and a matter of racial equality. The direct care workers in nursing homes are primarily Black women who are over age 40 plus. We are not only failing to attract new workers into these jobs, but we are also trapping those who are currently in this workforce in poverty. Vote yes on House Bill 933. Thank you.
For the work you do. We really appreciate it, and thank you for taking time to be here with us. It really makes a difference, okay?
Thank you.
Want you to know that before you leave. Next, please.
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the committee. My name is Sam Williamson, and I'm an attorney with the Public Justice Center. I'm here in support of HB 933 with sponsor amendments. Maryland's nursing facilities are currently experiencing a staffing crisis. The average nursing staff turnover in Maryland facilities is 49.5% per year. When turnover rates are this high, it harms quality of care. Staffing instability is tied to worse health outcomes for residents. For example, more short-term residents fail to improve enough to discharge to the community. Long-term residents have less independent mobility and are less able to do their activities of daily living. I have spoken with residents who have told me that they are left in soiled clothes for hours and that they are afraid that they will be left to die because there are not enough staff to respond to their call bells. The leading causes of staff turnover are low wages and lack of benefits. Over 1/3 of certified nursing assistants in nursing facilities rely on public assistance to make ends meet, and 40% do not have employer-sponsored health care. We must do more to ensure that those who care for our loved ones can sustain their life-saving work. With sponsor amendments, this bill will increase transparency in how nursing facilities spend their revenue. With this additional data, we can ensure that we properly invest in our care workforce. For these reasons, the Public Justice Center urges a favorable report on HB 933. Thank you.
You have a couple more people on your panel, right? Let me call the Acting Secretary of Health. And also, I believe, Chris Myers.
Thank you, Chair Pena-Melnick, Vice Chair Collison, and members of the committee. It's good to see you all. Hope you all are doing okay.
Here, except you do not get a free, cup of coffee.
No drinks back here, right, in the gallery. It's good to be here. The department's here in support, favorable with amendments on this particular bill.
Senator Charles, how are you? How are you?
I'm doing good.
Good.
JPR doesn't have any hearings.
Oh, Senator Charles used.
Shadow over and let him see some hearings in place.
Wonderful. Well, you're with a good person. He used to be on this committee. He misses it. Well, we miss you too. Come anytime, okay?
All right, now.
Welcome. Thank you for being flexible. You may go ahead.
Anytime. Department's here to support with favorable with amendments as introduced. I just want to talk about this for a little bit. The department acknowledges the intentions around this particular bill, which is to get more transparency around nursing home staffing and wages. We have a process that you've already heard to collect information on cost reports from nursing homes. What our amendments would simply do would allow for more detailed reporting on those cost reports in order to get the data and information needed in terms of funds that nursing homes are making directly to the direct care workforce. And also we would report on that annually. We have an every 2-year process so that we collect this particular information. So we would begin to revise our cost reporting with our particular vendors at the start of calendar year 2026. That would inform any future policies, particularly around, as originally the bill was intended, that we're removing as part of the amendments, which is some type of standard or percentage of nursing home revenues going directly to direct care wages. Let's get the data first, make data-informed decisions in terms of this particular work. And the department requests favorable with amendments, and I'm happy to take any questions that you might have.
Thank you for working with the sponsor. And we will need those amendments because we don't have them
Okay.
I don't have it on my, unless, I don't have it.
Jacob, if you're listening, please email the amendments.
We don't have them. No one has them, not even the analysts, so we need them.
Make sure you guys have them.
And actually, before we get to questions, there is a Christina Moore. All right? And I think that will complete your whole panel, and we'll open it up for questions. Good afternoon.
Good afternoon, Chair Pena-Melnick and members of the committee. My name is Christina Moore, and I'm a chief attorney at Maryland Legal Aid, leading the Baltimore City Administrative Law Unit with legal expertise in public benefits and administrative law. I wasn't served the amendments, but I am pleased to request a favorable report of the original bill with clarifying amendments. This bill would require skilled nursing facilities to spend at least 75% of its revenue on direct care workforce wages, and I note this bill is comparable to New York Public Health Law 2828, which requires a minimum of 70% of revenue to be spent on direct resident care. As I testified last year, Maryland Legal Aid has seen a major change relating to the purchases of skilled nursing facilities. Increasingly, these healthcare facilities are being purchased by private equity firms which seek to maximize profit at the cost of ensuring adequate staffing and acceptable patient care. According to the Maryland Healthcare Commission's 2023 study, 74% of skilled nursing facilities are owned by a for-profit company. By way of example, Maryland Legal Aid represented Mr. M, an older adult who was admitted to a skilled nursing facility over 1.5 years prior to the representation provided and had stabilized from his lower leg amputation, which had been complicated by antibiotic resistance. In that recovery and stabilization time, no one assisted him with an application for Supplemental Security Income, SSI, which would have opened opportunities for him for housing. Rather, at the time of his stabilization, he no longer met criteria for long-term care medical assistance, and the facility intended to discharge him to a homeless shelter, blaming social work turnover for their failure to prepare him. In this instance and many more, adequate staff would have improved our client's experience and reduced reliance on the institutional setting and allow clients like him to invest in the community. We support the bill with 2 amendments. First, we recommend defining revenue in the statute. We also recommend that direct care professionals include behavioral health workers. This bill is a crucial step toward ensuring the delivery of care, that delivery of care remains prioritized over profits. Thank you.
Thank you. So we're going to open it up for questions now. Are there any questions of the delegate and his panel with the amendments that he proposes? Vice Chair Collison.
Thank you, Madam Chair. And Acting Secretary Moran, thank you for working with the sponsor on the bill. In the reporting that you get currently from nursing homes, is it the total budget or only the Medicaid budget that you get? And maybe it's the same, and I'm not
So
sure.
they're Medicaid cost reports. So what we get is a number of different data components, right, related to Medicaid reimbursements. We get information on the facility related to ownership. We get operating expenses information. We also get broad categories in terms of nursing care services as an example, and these particular amendments would allow us to break up what we receive on those cost reports by specific provider type in terms of direct care wages and investments that those facilities make.
So those are all expenditures. Are revenue?
Yeah, so
also
included also in there would be, the reimbursements that the Medicaid program makes for those facilities as well. It's how we also do our rebasing on an every 2-year basis. We use the cost reports from these particular firms to then look at nursing home rates on an every 2-year basis. So we get all of those things in this process.
Great, thank you.
I have Delegate Kerr, followed by Hill.
While you were giving your testimony, I looked up the amount of salary and benefits that in a company that should be dedicated to salary and the amount of the budget that should be dedicated to salary and benefits. So I'm wondering how you got at the 75% number? Because what I found was that 20 to 35% is customary for a for-profit business and 50 to 75% for a nonprofit. Am I looking in the wrong place?
Are you looking at me, Delegate Kerr? So there have been different thresholds set across the country. New Jersey set 90%, New York set 70%, Massachusetts by regulation set 75%. A couple of things about those definitions. They were looking at expenditures towards direct care, which encompasses more than salaries and wages and benefits. So direct care could also include, in some of those statutes and regulations, could include housekeeping supplies, could include dietary supplies, kitchen supplies. So they took a more expansive look in Massachusetts, for example, at how to define direct care. They eliminated administrative positions. So you were eliminating any kind of corporate managerial or administrative operator positions, director of nursing. Does that answer the question?
Yeah, it certainly explains it a little better. I'll look at Massachusetts and the others you mentioned. Thank you. Thank you, Madam Chair.
My pleasure. Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate, for the bill. Secretary Moran, I understand that the amendment is going to take out that 75%. You're going to look at the data. I'm curious about any comments about the repercussions, the recoupment of department funding and position of corrective plan or suspension. Do you have any thoughts about those kinds of?
You mean as enforcement mechanisms? Yeah, so the opportunity, I think, for us is to achieve the goal of the bill, which is to get more transparency as it relates to wages. And then we, as a department, obviously within our regulation arm, have a number of ways in which we could look at that information in the future to set regulations that you're seeing of states in the future. We have not done sort of that discernment yet. We really believe that we want to collect the data and get the data before we start thinking about what some of our options are. And I also think that that's prudent too for stakeholders in this regard, for all parties, right? For both the nursing facilities, SEIU workers, others, to have.
So the amendment removes that section too?
Correct, correct, at this time.
Thank you. I don't see any other questions. I have to tell you that Jacob did just send the amendments, so your message worked. Okay. Thank you so much. I don't see any questions. You did send the amendments, and then just work with the subcommittee, okay? So we're gonna actually now call an unfavorable panel, and it is Allison Zaborowski and Donna Kaufman. And if you could testify, if your position changed listening to the amendment, that would be great if you could let us know. Good afternoon.
Good afternoon again. And for the record, I'm still Dana Kaufman, and I'm here on behalf of Lifespan Network. And our position does change with regards to the study language replacing the bill. We appreciate that. We did have some concerns about the original bill. I do want to kind of backtrack a little bit, though, and just talk a little bit about you've heard cost reports. So basically, every year, nursing homes, which the rate setting system for nursing homes is very complex. Every year, the nursing homes have to complete and file with the department a cost report. Those cost reports have 4 cost centers: nursing, capital, other patient care, and routine and administration. So pretty much any cost that is affecting the nursing homes is reported on that cost report. It is that cost report that is used for the distribution of the budget. So, you know, if you look at the state's budget and the nursing home budget as a pie, it's the cost reports then that kind of slice how that pie is going to be divided. The reports are reviewed by Myers and Stauffer, a leading accounting firm in the state. So they're not just submitted to the health department, but they are under contract with Myers and Stauffer to examine. And then, as you heard, every 2 years almost, we go through a rebasing. The rebasing is basically like, for example, our 2025 rates are set based on our 2022 cost reports, which are then adjusted for inflation, or no, I shouldn't say inflation, just CPI, which is not as high as inflation. So that's just to kind of give you a better overview of what those cost reports are and what they're used for and how detailed they are. And I will also say, just on the budget language, we did receive it. We're taking a look at it. We think it needs some tweaks, so we asked for a little bit of time to do that and work with some of our finance experts. So thank you very much.
Thank you, Madam Chair, Madam Vice Chair. Allison Siborowski here on behalf of Leading Age Maryland, and I had signed up as unfavorable before I saw the amendments. And so I will say that we are in support of further evaluation of the current state of wages and benefits in Maryland nursing homes. And we are reviewing and would look forward to working with the proponents and sponsor on the language. I do just want to note that the current bill and even the amendments, so far as I can tell, do not truly take into account the true cost of quality care. Wages and benefits for direct care are not the whole picture, and this was even noted a few minutes ago by Ms. Baylog at SEIU. So I just wanted to give an example of what this looks like. Several of our members pulled financial information this week to calculate the percent of nursing home revenue that is spent on direct care wages and benefits, as was defined by the original version of the bill. Several of these providers came in around the 50% range. Several came in between 60 and 74%, but none were above 75%. However, these communities all have 5-star staffing ratings from CMS, and when compared to other nursing homes in the area and across the country, they have higher wages, lower turnover rates, higher staffing ratios, and higher weekend staff hours. So an arbitrary requirement that does not accurately take into account the true cost of quality care would be detrimental. So we look forward to continuing to work with the sponsor and proponents, and thank you for your time today.
Are there any questions? So I need you to work with the sponsor, because this is really the right thing to do, okay? And I know that you may not like how it came, but I think that the compromise, the amendments are a compromise, and it's important, all right? Thank you so much. Thank you. Appreciate you. Tammy Bresnahan? ARP Maryland? No? Is she virtually? It says both, but I don't. Yeah, I don't see her. All right, so this actually concludes the bill hearing on House Bill 933. I want to thank everyone that's sitting, that is being patient. I want to also encourage you to work with the sponsors. I know you always do, and we appreciate you. We're going to now call House Bill 939, and it's Delegate Peña-Melnick. Myself, I'm going to give it from here. If I may ask my panel to come up, and that is former Delegate Ariana Kelly, Robin Elliott, Yakia Johnson. Will you be so kind if you can come up? And I'll sit here so I'm not disruptive, if I may. So, colleagues, I'm pleased to present to you House Bill 939, which is titled Maryland Commission for Women, Maryland Collaborative to Advance Coverage of Over-the-Counter Birth Control. The bill creates a collaborative with state agencies, consumer representatives, pharmacies and pharmacists,
and ensures to support implementation of Maryland's existing requirements to cover, for coverage of the over-the-counter birth control. The bill does not have a fiscal note. Isn't that wonderful? And we have the support of the Maryland Commission on Women, who's willing to staff it and do the work. And thank you. The Maryland Department of Health, thank you. And the Women's Caucus, thank you as well. Today, we'll also hear from policy advocates from other states and national experts who support Maryland's work on this issue. And we were the first state to pass a requirement for over-the-counter birth control. And so you're wondering, why are we here? We're here because it hasn't really worked, right? And I'm going to tell you the numbers, and I was a little shocked when I found out about it, and that is the reason why we have the bill. And if you ask, are these birth control approved? Well, in the United States, the FDA has approved 2 forms of over-the-counter birth control. Plan B, an emergency contraceptive approved in 2006, and O-pill, a daily birth control pill approved in 2023. More than 100 countries already allow this kind of access to multiple kinds of over-the-counter birth control, and they have been found to be safe and effective. Over-the-counter birth control eliminates the need for a prescription. It makes it easier. That was the reason why we passed it. Maryland became the first state to require coverage of over-the-counter birth control. And it was a bill in 2016 sponsored by Senator Dolores Kelly and Delegate Ariana Kelly. And then in 2018, Delegate Shelley Hettleman, who is the Senate sponsor on the cross-file for this bill, and Senator Dolores Kelly sponsored legislation that extended the over-the-counter birth control requirements to Maryland state employee and retiree benefit plans. So since then, we have inspired 10 other states that have actually, cover it, are doing it, and are covering it. So what does it look like and why we're here? I want to give you just a little background on what is happening and why we need this bill. So the bill has been in the books, I believe, for 10 years now. And from 2018 to 2019, state advocates worked with the Maryland Insurance Administration to ensure insurance plans that they cover it properly, right? We did that. In 2019, a state employee was unable to access the over-the-counter birth control, and birth control, and Senator Hettleman worked with the Department of Budget and Management to fix it. CVS Caremark, who we used to have, right, because we have someone new now, the state's pharmacy benefit manager at that time issued a bulletin clarifying how pharmacies should process the claims to make it easier. In 2020, a secret shopper survey by Maryland NAREL revealed that many people were still unable to use their insurance for over-the-counter birth control. 2023 to 2024, Maryland participated in a national coverage collaborative leading to the publication of a report, right, that outlined the best practices. And despite all these efforts, we have not improved. And what really was alarming to me, and I became concerned, is that I discovered that only 139 claims, okay, for over-the-counter birth control were processed by the state employee and retiree benefits. For O-pill, just 4 claims were covered in the first 8 months when it was available. And this has been in effect for 10 years. This isn't a failure of any one agency, and I'm not blaming anyone. It's a sign that we need to coordinate our efforts to make sure that this birth control coverage is a reality, to make sure that it actually works. To move forward, what this bill does, if you're wondering how can we fix this, this bill will direct the Maryland Commission on Women to convene a collaborative of state agencies, consumer representatives, insurers, pharmacy benefit managers, pharmacists, and pharmacies to develop a clear and standardized guidance on how pharmacies should submit a claim for over-the-counter birth control. It will increase awareness among consumers, pharmacists, and healthcare providers about this coverage, and will explore ways so that community-based partners can provide the over-the-counter birth control to uninsured individuals. This effort will build on a wealth of existing work, including the responses to a 2023 for information that was actually required by the Treasury Labor and Health and Human Services Department. So to conclude, I'm not going to bore you. We have had it on the books for 10 years, 139 claims for one, 4 for the other. It doesn't work. We need to do better, especially in light of what's happening at the federal level. People in Maryland need protection, and they need access. I hope that you can give this bill a favorable report. Thank you. Who will be next?
Thank you, Madam Chair. I'll go ahead. It is so wonderful to be back home. Thank you. I'm looking around the circle, and I'm just so thrilled to be here. And as all of you current HGO committee members know, there's nothing we like more than being led and directed to do something by our chair. So I saw this piece of legislation, and I was thrilled that the Maryland Commission for Women could be part of this very important work. By way of a little bit of background, because this is my first time before you all in my new role as Executive Director of the Maryland Commission for Women. I did leave all of you a copy of our most recent report on your desk, the Women in Elected Office report. The Maryland Commission for Women was established by the legislature in 1971. Particularly, it was established by the women legislators of Maryland. And we were created in order to identify problems facing Maryland's women and then make recommendations to the legislature and the executive branch for meaningful solutions. And in fact, our statute, which you so thoughtfully crafted back in 1971, so I don't think anyone was here then, but that statute specifically authorizes the Maryland Commission for Women to convene advisory groups like the collaborative that's in this proposed legislation. So the structure of this legislation will allow the Commission for Women to partner with the relevant state agencies and the community groups within the collaborative to make these recommendations to you that would come in the form of an interim report and a final report. I like to think that this is an opportunity where the Maryland Commission for Women can solve that eternal problem that you all face. This is an excellent idea, and who is going to staff it? We are here, and when I got the request for the fiscal note, I looked around our existing budget and determined that we can and should be doing this work with our existing resources. So I'm very excited that we are able to do so. I am very much looking forward, should this committee pass this legislation, looking forward to engaging in this project, working collaboratively with the relevant stakeholders that are listed and coming up with some meaningful recommendations so that we can fully implement this legislation that you so thoughtfully passed in 2016. Thank you so much.
Thank you for your work and for being willing to work with us. Next, please.
Good afternoon, Robin Elliott. I'm here today on behalf of Reproductive Justice Maryland. Just thrilled to be in front of you on this issue. Maryland was the first state to pass over-the-counter birth control coverage. Now there are 10 other states, and multiple other states have voluntarily extended coverage through their Medicaid program. I know that we can get implementation right in Maryland. There's been a lot of work done at the national level. The solutions aren't rocket science, as we say. They are actions such as just making sure that pharmacies know how to bill for the product. They have a lot on their plate, so lifting it up. Communication with consumers. Can we, for example, I know there's not additional resources, but can we integrate consumer awareness about over-the-counter coverage in existing birth control and reproductive health awareness campaigns? So those are the types of things that the commission and this collaborative will be able to examine. Lots of work on the national level to build upon, and just want to thank the sponsor in particular. There are a number of members of the collaborative who are consumers, because it's so important, especially with over-the-counter coverage, to center the solutions on the consumer, who is the one who is going to be accessing coverage. So with that, very much appreciate the committee's time and happy to answer questions.
Ms. Jakia Johnson?
Oh, I just received a text from her. She's about 10 minutes away, so
Okay.
unfortunately she's...
So, all right. So why don't we open it for questions for this panel? Delegate Hill.
Thank you. So just clarifying and then a detailed question. The clarifying question, this is to the representative from the commission, former Senator Kelly. I want to be clear that this is sponsored by the chair. You're in full support with the commission, having been on this committee for many years and being very familiar with it, and there's no fiscal note. So I'm clarifying that you feel there's a good chance that we may come aboard to support this legislation.
That would be my hope, and I do want to take the opportunity to make sure that the members of the committee know that not only do I support it, does the staff support it, but we have 25 commissioners who have been appointed and confirmed across the state, from communities across the state, and they voted unanimously to make this a priority project for the Commission for Women in the coming 2 years.
Okay, and then the detailed question to you or the sponsor. When we talk about how there has not been the take-up of the over-the-counter, how does that compare to, are we saying that contraceptives aren't being used, so we're not seeing a increased use and that people are using more prescriptive contraceptives, or we're not seeing a switch from people using prescriptive contraceptives to over-the-counter contraceptives?
Okay. Thank you for the question, Delegate Hill. I don't think we have yet enough data. That is one of the things that the collaborative can look at. I think with over-the-counter contraception, we do expect there to be some people who go from prescription to using an over-the-counter method because there are less barriers. We also, though, expect that some people who are not regularly using contraception will be able to utilize contraception more easily. So we should really overall see an increase in accessibility.
And therefore a decrease in unintended pregnancies and a decrease in other unintended outcomes.
It's absolutely, it gives people the ability to control their lives.
All right, thank you.
Thank you. So based on the conversations that I've had, I found that it's a cost issue. The Plan B was, right now, you say that it's $40, $50, but I think it's 20 if people tend to buy it. But the thing is that may still be too costly. How can it is it possible for that cost to be eliminated and be also as we're doing with the other more, regular birth control that is prescribed?
I can take that if you'd like, Madam Chair. So yes, absolutely, Delegate Taveras, and you are spot on, and that is one of the goals of this collaborative. We want to make sure that at the point of sale, consumers understand that the current law in Maryland requires their insurance plan cover the cost even if the contraception is over the counter. So we need to make sure that those processes are working and make sure that the retailers are reimbursed for the costs and that the consumer is not bearing out of pocket something that they're paying for with their insurance plan. So yes, that would be for Plan B as well as for OPIL.
And in addition, I may one of the, also the charges for House Bill 939 is that it explores ways for community-based partners to provide over-the-counter birth control to uninsured individuals as well. It's one of the charges in the bill.
But right now they're paying out of pocket. I just want to be clear.
I don't know that, but the bill, if it passes, is going to look at a way to provide it
for people that can't afford it for free.
Okay, because I think that's the problem.
Okay.
Okay.
All right, you're welcome. Any other questions? Seeing none, thank you so much. Let's move on to Louisa Debkin. And will you be so kind and bring the virtual witnesses, and then we'll be done with this bill. Good afternoon.
Hello, Chair and members of the Health and Government Operations Committee. My name is Louisa Debkin. I'm a senior in high school and an intern with the Baltimore County Commission for Women, and I strongly urge a favorable report for HB 939. Access to birth control is a right that all women should have. When I was a freshman, there was a girl who got pregnant and eventually left the school at the mere age of 14. No pregnancy at that age is intentional, and she got pregnant due to a lack of accessible resources and a lack of education from the school. Access to birth control is not only critical to prevent unwanted pregnancies, but it's also used as treatment for a variety of medical issues. Personally, I am on birth control for a medical issue, but I had to wait over a year before I was allowed to go to the doctor. My mom had never been a big fan of medicines, and because of her opinions, I had to wait. There are so many different barriers for birth control that people from all different races, classes, and locations have to overcome. This bill will be critical in identifying locations that have a lack of access and ensuring that that changes. Certifying access to birth control is going to help me and my peers. There is always the topic of keeping children in school, and this bill is going to be one of those factors. Give us the chance to show the world what we can do. Thank you for your time and consideration on this urgent matter.
And thank you for making time to be here. We really appreciate your perspective. Are there any questions for this witness? Seeing none, thank you so much. Next, we have the virtual witnesses, please. Will you be so kind and unmute yourself? This is Ms. Catherine Shamzad. Thank you.
Thank you. Chairwoman and members of the committee, thank you for the opportunity to be with you today in support of this bill. My name is Kate Shamzad, and I'm the Director of Policy at the New Jersey Healthcare Quality Institute. On behalf of my organization, we commend Maryland by taking this critical step in advancing access to OTC birth control. My experience serving as a state advocate on the National Free the Pill Coalition and my organization's experience in New Jersey has demonstrated that coalition-driven strategies are essential to support implementing successful contraceptive coverage policies. Access to birth control is a fundamental component of reproductive autonomy and public health, and removing barriers to contraception is critical, allowing individuals to make informed decisions about their reproductive health. Similar to Maryland, New Jersey has been a leader in implementing OTC contraceptive coverage, and we found that through our work on advancing reproductive health, that establishing a robust multi-sector coalition to support policy advancement, education, and accessibility yields a higher rate of engagement and implementation success. Through the establishment of the Maryland Collaborative to advance implementation of coverage for OTC birth control, the inclusion of state agencies, advocacy groups, health insurers, pharmacists, and public health experts will be essential to overcoming barriers to access. Maryland has long been at the forefront of reproductive health policy, and this bill provides an opportunity to continue to lead the way in the U.S. for over-the-counter contraceptive solutions. It will provide a national model for effective coalition building and policy to ensure all individuals can access contraception without costs or systemic barriers. I urge the committee to pass this bill and invest in a collaborative framework that will further advance reproductive autonomy for all Marylanders. And I thank you so much for allowing me to be with you today.
Thank you for being with us. We really appreciate you. Are there any questions for this witness? Seeing none, thank you so much. Have a great evening. Next, please, Ms. Bria Good.
Good afternoon. My name is Bria Good, and I serve as the Senior Policy Advocacy and Research Manager for the Free the Pill, a project of IVA's reproductive health dedicated to expanding access to and coverage of over-the-counter birth control. As a proud Maryland native, born and raised in Prince George's County, and a graduate of the University of Maryland, College Park, I am pleased to be able to provide information on OTC birth control for the committee to consider on Senate Bill 674. Maryland has long been a leader in increasing access to over-the-counter birth control, from becoming the first state to mandate insurance coverage of OTC contraceptives in 2016 to requiring college campuses to provide access to contraception during school hours. However, despite these groundbreaking policies, barriers to implementation continue to limit their real-world impact. Insurance coverage for OTC birth control remains inconsistent, creating unnecessary challenges for Marylanders seeking essential reproductive health care. As we know, policy alone does not guarantee access. Coverage is only meaningful if it works in practice. This bill is a critical step toward bridging this gap. By ensuring that coverage is implemented effectively and equitably, this bill will make it easier for Marylanders to access birth control when and where they need it. Establishing an implementation collaborative that brings together key stakeholders, including pharmacists, insurance commissioners, reproductive justice advocates, public health officials, and researchers. It will help develop practical solutions to address coverage barriers, educate the public on their options, and ensure seamless access to contraception at pharmacies and other points of sale. This bill is about making sure that no Marylander is left behind. Maryland has set the standard for expanding access to over-the-counter birth control, and passing this bill will ensure the state remains at the forefront of this movement. This legislation will not only solidify Maryland's leadership, but also help transform policy into meaningful, equitable access, breaking down systemic barriers and advancing reproductive justice and autonomy for all. Thank you for your time and consideration.
Being with us, we appreciate it. Let me open it up for questions. Are there any questions for this witness? Seeing none, thank you so much for being with us. We appreciate you. Let's go to Bev Samus. Is she on virtually? She's not? All right, and I'm going to call one more time. Ms. Johnson, is she here yet? Okay, so this concludes the bill hearing on House Bill 939. Let's move on to House Bill 718. Delegates Rosenberg and Peña-Milnick, Maryland Health Insurance Coverage Protection Commission established. Delegate Rosenberg. And Delegate Rosenberg, if we can bring, you have a panel. If we could bring on Vincent DeMarco, Donna Kaufman, Marie Grant, Maryland Insurance Administration Commissioner Marie Grant. I can tell you, I can actually say that now.
There's one more step, Madam
Okay.
Chair.
Well, we're going to claim it, Marie.
It's called the
We're going to
Senate,
claim
right?
it.
The Senate part is done.
Okay.
Okay.
Good afternoon.
Madam Chair and members of the committee,
Want to move the microphone closer to you. Thank you.
Madam Chair and members of the committee, every day in this committee, we are reminded of the importance of Medicaid to the operation of the health system in Maryland. Earlier today, we heard testimony about nursing homes. Every day we read in the newspapers that a huge cut will be made in Medicaid by the Congress as it enacts the budget for the upcoming fiscal year. Whether it is nursing homes, the all-payer system, Medicaid, money is essential to the work that we do in this committee for the citizens of our state. The chairman suggested to me that we had addressed this problem once before, in fact, 8 years ago, when Medicaid was also on the chopping block. And we created a commission to review those changes, to review the impact of that loss of Medicaid money from the federal government and how we could minimize the harmful effect that it would have on our healthcare system and, most importantly, the citizens, the residents of this state who use that system. This bill is a reintroduction, if you will, of the bill from 8 years ago. And I just think circumstances make clear how essential it is that we have a separate body conducting an ongoing review of Medicaid during the interim. We can't wait until we come back in next year to address those problems. We need to have input from the legislature in that process. As much as we respect the health department, the insurance commissioner, we need to have legislative involvement, and it would not be solely legislative involvement. Based on the experience from 8 years ago, this commission, the bill lists the various entities, the various players, if you will, in our healthcare system that would have a representative on this commission. And by evidence of those who have asked my office to be added onto the bill, there are a few others who would like to be part of this, process. For all those reasons, I would urge a favorable report on this legislation to create the Health Insurance Commission. Oh, and I would add one more thing. There is a significant amount of discussion that there should be a work requirement for Medicaid. That, to the best of my knowledge, was not part of the discussion 8 years ago. It was part of the discussion on welfare reform some 20 plus years ago, and we did, at that time, I was the chair of the relevant subcommittee on appropriations that had responsibility, and we put together a bipartisan plan. And I think the language of the bill, as I reread it today, is broad enough that it would include any work requirement that is imposed by the federal government to review what we've done in the past and what we think is appropriate at the current time. So for all those reasons, I would urge a favorable report. Thank you.
Thank you. Why don't we have the pending Secretary, Commissioner of the Maryland Insurance Administration next.
Thank you so much, Madam Chair, Madam Vice Chair, committee members. Marie Grant, on behalf of the Maryland Insurance Administration, in support of this legislation. I think this is a really important effort, bringing together legislators, the executive branch, and stakeholders to talk about some pressing problems amidst a lot of uncertainty, I think, about federal actions and their impact on our markets. We have had a record-breaking year in terms of exchange enrollment. We have new plans on the market. We're at a point where we have a very functional, healthy market in the individual market, and certainly we want to keep it that way and work with you all to keep it that way. We also are assisting in staffing this commission, and we would be happy to do so, and just look forward to working with you all on these important questions and issues.
Next, please. Vinny.
Madam Chair, Madam Vice Chair, members of the committee, my name is Vinny DeMarco with Maryland Healthcare for All Coalition. Thank you so much, Madam Chair and Delegate Rosenberg, for putting in this bill. We strongly support it. The commission that Delegate Rosenberg referred to, it was created in 2017. I was honored to serve on with you and Senator Feldman being great co-chairs, and a lot of wonderful work came out of that commission. As you know, the reinsurance program, the easy enrollment program, the young adult subsidy program, which thank you for re-upping that today. And so it was a big success. And I'm here to say that we desperately need that again, as we're under threat again, as Delegate Rosenberg so well put it. And just say to you that we at Maryland Healthcare for All Coalition will do whatever you need to get this bill enacted and then to implement it, to protect Maryland and to move forward on healthcare as you have done so well. Thank you.
And thank you for your work over the years, everyone here. Go ahead.
Madam Vice Chair, Madam Chair, Madam Vice Chair, members of the committee, Dana Kaufman. I'm here on behalf of MedChi in support of this bill for the reasons that you've heard. We appreciate having a designated seat on this very important commission. And I'm also going to request that I think another seat that needs to be on this is the home and community-based services industry. I did not think about that before until yesterday when the Medicaid analysis came out, and the Department of Legislative Services is recommending a 2% cut to their rates, which would be devastating to that industry that serves such an important Medicaid population. So as we're looking at these across the board, I do think that that is an industry that needs to have representation that is often overlooked. So thank you very much.
Thank you. And I believe that this is your panel for now. Later, we'll call a favorable with amendment panel to be balanced. I'm going to open it up for questions now from the committee. Are there any questions from anyone? Seeing none, I do have a question, if I may, and I usually wait to the end. My question is, this is actually this commission is going to be looking at more than Medicaid, right? It's going to look at anything that is done, any changes to the Affordable Care Act, right? As well, those consumer protections in there. It's going to look at Medicare as well, correct? And any insurance changes that come from the federal government. As we know, there's a lot of changes that are being proposed. And in Maryland, and Delegate Rosenberg is correct, we did a lot. And we have been able to reduce the number of uninsured in Maryland from 14% to 6%. And we're on the threat. So this commission will look at all of that, correct?
Absolutely. It definitely needs to be a broad-based review of every change that is before us in light of federal action.
That's right. And Maryland has led. And when that commission was actually implemented, all those policies that you mentioned, were passed. And can you, Mr. DeMarco, talk about one of those policies, the young adults, and how many young adults are covered now because of that?
Well, thank you for that question, Madam Chair. About 60,000 young adults are benefiting from the Young Adult Subsidy Program, which this legislature enacted in 2021 after the original Health Insurance Coverage Protection Commission recommended a subsidy program to the legislature. And so that was a big success. And tens of thousands of people are enrolled because of the easy enrollment program, which once again, that commission recommended to the legislature. And as you know, the reinsurance program was recommended by that commission, which helps hundreds of thousands of people afford their health care. So it was a big success, the first commission, and I believe this one will also be.
And Commissioner Grant, under the reinsurance program that came out of that commission, that program that we passed, how many people are in the individual insurance market?
I think we are at over 300,000 folks enrolled in the individual market, Madam Chair. I think nearly 250,000 in the exchanges open enrollment for 2025, which was really successful. And it's also been successful in bringing down rates overall.
Tell us the percentage that that it has brought down the rate.
I'm embarrassed that I can't remember it off the top of my
30%.
head, Madam Chair, but I also do know that isn't that, yes, that is so. But just to add, it has also kept our rates among the lowest in the nation, which is really important for enrollment too. That affordability is very important.
That's good. And the last time we did something like this exercise, we actually also codified some of the provisions of the ACA in Maryland law.
Yes.
Commissioner, can you tell me if you recall what some of those are?
Yes, absolutely. So I think, and we're talking a little bit about updating in a couple of bills, but the zero cost preventive services, which is very important, guaranteed issue, guaranteed renewal, coverage of dependents up to age 26, prohibitions on lifetime maximums, like qualifications around cancellations and rescissions. All
and
of those
is
really important.
you cannot discriminate for pre-existing condition one of them as well?
Absolutely.
Thank you.
Yeah.
Are there any other questions? Delegate Taveras.
Hi. There seem to be a lot of requests to add folks. How big do you think that the group will need to get in order to be effective. I mean, like, you know, to have the voice of, you know, the health parity, LGBTQ, MACO, you know, these are some of the folks that want to come on board. But I mean, how big do you think?
The subcommittee will be deciding that.
Okay.
Yes, because everyone wants to be on it.
I mean, people,
The subcommittee will be making that decision.
they're like adding themselves already.
Yeah, it is a very popular bill.
All right, thank you.
Yes, if this was a contest, it would win the popularity contest. Seeing no other questions, thank you so much. And thank you, Delegate, for your leadership.
Thank you,
And
Madam
thank you,
Chair,
everyone, for
your
working on this. We're going to go now to favorable with amendment. N. Seacock, Robin Elliott, Brett Lininger, Julia Schreiber, and Charlotte Hoffman will be the last witness for this bill. Will you please come up? And if there are not enough chairs, please bring a chair up. Thank you. And Delegate Taveras, the last time, the commission had about 20 members. So let's just say that they have to fit in these chairs, and there's only 23 chairs. So that gives you the answer. All right, next, please. Good afternoon. Who would like to get started? I know you guys are not shy.
I'm happy to.
Okay.
Hi, good afternoon. Ann Seacott, testifying on behalf of the National Council on Alcoholism and Drug Dependence, the Maryland chapter. Thank you, Madam Chair, Madam Vice Chair, sponsor, and committee members. It's kind of sad that this is such a popular bill because it's sad that we need it. But we do. We are in full support of it. And so I'm actually not asking for a seat. Asking for a topic, and that is to make sure that the Federal Mental Health Parity and Addiction Equity Act is included in what is examined by the Commission. The final rules that were issued in September for the implementation are already in court being challenged. We are not sure if the federal government is going to defend the case. We don't know where this is going. None of us does. So we would love to make sure that the issues around mental health and substance use parity that you all have spent years on trying to help make sure the federal law gets enforced here at the state level, want to make sure that that gets included in the discussions. Of course, if you want to throw a seat in there as well, somebody with expertise in that area, that's fine too. But we really would love to have make sure that the topic is covered by this commission. Thank you.
Okay. Hi. Maybe I should move over so I can be in the camera. There we go.
There you go.
Hello, I'm Charlotte Persephone Hoffman, and in addition to the wonderful duties that I was here for last Friday, in which you probably remember me, I am also the policy director at Trans Maryland, and I'm here today to request not necessarily a position for Trans Maryland ourselves, but to emphasize the importance when we're bringing together a commission like this to focus on the communities that are being most affected. And this is going to affect everyone in Maryland, but there are identifiable communities that the federal administration has already put their targets on. This is not just the transgender community, it is also immigrant communities, it is women seeking reproductive access. We need to ensure that the commission includes the voices of people who are parts of these parts of these communities and who make this work like part of their life. Because I've seen so many times going into a room where just to talk about like trans healthcare or reproductive rights or whatever, where I've had sympathetic legislators or folks in the insurance administration, et cetera, who have said, oh yeah, we get what you're saying. And then once I start talking to them, they're like, oh, we don't actually get it. like, explain this to us. Like, there's so many complexities here. So we really want to make sure that this commission is open to the people being affected. And also, I do want to emphasize the importance of ensuring that we think about not just like the federal legislation, but the regulations implementing those federal legislation. So not just the ACA, not just Section 1557, but the regulations implementing Section 1557, and how, you know, we're going to be seeing the non-discrimination protections gutted across the board, and the Insurance Administration in Maryland doesn't necessarily have the power to issue its own regulations there.
Thank you. Next, please.
Good afternoon, Robin Elliott. I'm here today representing the Maryland Community Health System, which is a network of federally qualified health centers. So the request that we have is just to include federal public health grants in the range of issues that the commission will look at. There are grant programs such as the Breast and Cervical Cancer Screening Program that provides really, really important support and services, mostly at local health departments for people who are uninsured or underinsured. And so when thinking about coverage, just being inclusive of those types of programs. And with that, we look to really look forward to enjoying working with you all and the commission on what to do next. Thank you.
Thank you. Love the short testimony. Who's next?
Thank you, Madam Chair and members of the committee. Brett Leininger, here on behalf of NAIFA Maryland. NAIFA is the National Association of Insurance and Financial Advisors. Some of our members are health insurance agents, producers, employee benefit specialists. I think our expertise would be valuable to the discussion here in support of the bill, just to be added to the long list. We're very close to the consumer, to the employer, and I think our expertise would be valuable to the discussions of the commission.
Good afternoon, Madam Chair and members of the committee. My name is Julia Schreiber. I'm the program director for the State Health Insurance Assistance Program and other programs at the Maryland Department of Aging that focus on health insurance counseling. I'm here to testify on behalf of the department that we are favorable with amendments for HB 718. We enthusiastically support the creation of this commission and simply request that we are added to it, which we request an amendment that we're added to it, which we've included in our written testimony, discussed with the bill sponsor, and shared with committee staff. We regularly help older adults navigate all aspects of Medicare and their health insurance, so we're well positioned to contribute to this group's work and elevate the perspective of older adults moving forward. Thank you for the opportunity to testify today. We respectfully urge a favorable with amendments report on HB 718.
I'm going to open it up for questions now. Are there any questions for this panel? I just want to thank you all for your advocacy and for your willingness to serve, okay? And for your perspective. We appreciate it. This actually concludes the bill hearing on House Bill 718. Next, we have Delegate Shetty. You have House Bill 936 and House Bill 974. Let's go with House Bill 936 first. Health insurance cancellation and non-renewal of coverage require notice. And you have a panel, if you could come with it. I think it's, we have Marie Grant. Is she part of your panel? Or?
Yes.
Yes. Marie, will you be so kind and come up? She was just here. Can someone check and see if Marie's outside, please? Thank you. All right. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair. I also have a virtual witness who's part of my panel.
We'll bring it up. Will you bring
Yes.
the virtual witness up?
Thank you.
Thank you.
Thank you so much. It's Ms. Cornejo. Chair Pena-Melnick, Vice Chair Collison, esteemed members of the House Health and Government Operations Committee. For the record, my name is Emily Shetty. Thank you so much for the opportunity to provide testimony in support of House Bill 936, a bill that ensures health insurance policyholders receive proper notice when their health plans are canceled or not renewed. Under current law, individuals do not always receive adequate and timely notice, which leads to gaps in coverage that can have serious consequences for their health and financial stability. HB 936, as introduced, requires insurers to send electronic notices of cancellation or non-renewal if an individual is opted in with their carrier, while also including information on alternate coverage options like the Maryland Health Exchange. This ensures policyholders have the resources that they need to make informed healthcare decisions within the special enrollment period when they actually can make those decisions. While there are measures in place to notify policyholders of a change in their coverage via mail, it's not always 100% effective. So for those of you who don't know, during the interim, I have the privilege of teaching at two amazing universities here in Maryland. This fall, a student of mine approached me and shared that her father had passed away recently, and their health insurance had lapsed because the cancellation letter that was mailed after the enrollment period, that they received it after the enrollment period had closed. So that left them without meaningful coverage for the bulk of the fall. That's what inspired this piece of legislation. It goes without saying that what my student's family went through while grieving the loss of her father was extremely challenging. On top of that, losing health coverage unexpectedly when they needed it most was pretty devastating. This bill promotes transparency. It ensures that those affected have the time and information needed to seek alternative plans without disruption. By strengthening notification requirements, we can reduce the risk of individuals unknowingly losing access to essential medical care. HB 936 is crucial given the ongoing challenges in navigating our healthcare system. Unexpected coverage loss can result in delayed medical treatment, financial strain, and increased burdens on emergency services. I want to add that I've been really grateful to work with both the MIA as well as I've spoken with our insurance carriers. I know Mr. Sultano had accidentally signed up in opposition. I think I had asked if he wants to join. He actually wanted to join my sponsor panel to clarify on the record that they are support with amendment. Actually, so we did get those amendments back. We've shared them with HGO Council, and they have been, I believe, signed off by our carriers. So now the bill is workable, which is what the goal is, right? So thank you for your committee's consideration of HB 936. I respectfully request favorable consideration. And I'd like to introduce our virtual witness, if I may, Ann Cornejo. This is the mother of my student, Natalie, from the University of Maryland. So, Madam Chair, if it's okay with you, I'd love to have Ms. Cornejo share her story. Thank you so much.
Cornejo, how are you?
I'm good, thank you. How are you?
Good, thank you for being with us. If you could get a little closer so we could hear your beautiful voice, that would be great. Thank you.
Is that better?
Oh, it's okay.
Better?
You can get started. Yes.
Okay. Hello,
Thank you.
My name is Ann Cornejo, and on June the 16th, my husband passed away. Max had his own company, and we were all signed up through him with Maryland Health Connection for our insurance. After Max passed, I was totally overwhelmed, and it was one foot in front of the other just to make it through the days. On August the 16th, exactly 2 months after he passed, he received a letter from Maryland Health Connection telling him that his insurance policy was cancelled effective the date he died, June the 16th. We had been 2 months without insurance, and we had no idea at all. Fear and unease kicked in because I was completely blindsided. I contacted my work, but it's 30 days from the cancellation date to be able to get coverage with the life-altering event, and mine had been 60. My unease became full-fledged anxiety after I tried to sign back up with Maryland Health Connection, only to find out that to cover my family would be $800 a month. The monthly income coming into my home has gone down by 3/4. I'm already juggling to pay the mortgage and keep the lights on. I do not have $800 a month for insurance. I ended up doing what I'm sure many people have had to do, and that was conducting a Google search and signing up with some unknown cheap insurance that wouldn't even cover a flu shot. Luckily, thanks to open enrollment, we now have insurance through my work. I dealt with a lot after Max passed. It was all new territory to me. I had been married for 29 years. I weathered a lot, I dealt with a lot. But that episode, starting with that letter on August the 16th, almost broke me. I wasn't looking for handouts. I was just looking for a little bit of help to be pointed in the right direction and to not be blindsided. And I thank you for your time and for allowing me to speak.
I want to thank you for sharing your personal story with us. And I want to say on behalf of our committee how sorry we are for your personal loss. And know that your testimony means a lot to us and that we will certainly take it into consideration. Okay? You're welcome. I'm going to open it up for questions now, and then I'll call the favorable with amendment and the info, okay?
Thank you.
Delegate Hill.
Thank you, Delegate Chetty, for this really important bill and for taking this problem on. There are other problems with notice, and I don't know whether this bill has room to take on additional issues. One, as your witness testified, the fact that there was only 30 days after loss or a life-altering event. I don't know if that, we've dealt with extending what life-altering events are, but I don't know if we've dealt with that 30 days. And I also know of stories where people had insurance that was provided through a previous employer who just decided we're no longer going to carry, and they had no obligation, and it was left to the insurance company to notify them that your former employer is no longer with us. And so I guess I'm asking, this bill does something really important. Is there room in here for others, or that's for another day, another year, another bill?
Thank you, Delegate, for the question. I agree with you that sort of through learning about my student's story, and thank you, Ms. Cornejo, for doing such a beautiful job of testifying and sharing it so beautifully. I learned a lot about some of the shortcomings we have in this space. As you know, I am a lowly appropriator and certainly would defer policy considerations over whether it's appropriate to use this as a vehicle to extend the enrollment period. I welcome that discussion. The amendments that we've submitted do not take that into consideration. It's solely focused on the notification provision, but I welcome the feedback from the committee, and the amendments do have the support of all the stakeholders as drafted. So.
Thank you, Madam Chair.
Thank you,
And
ma'am.
Delegate, if I may, Delegate Hill, you may call Michelle Everly, and she'll tell you what we allow right now. I just did that yesterday, and see what happens, okay?
Okay.
Delegate Taveras.
Thank you. Hi.
Hi.
Thank you for this bill. It looks to be very important. I was just curious why we are not providing an equal type of notice 90 days before as well.
90 days before the termination of coverage. So I believe that current law does require that when, for example, a carrier is planning to, if coverage is planning to end, and I would defer to MIA as well as our carriers who are planning to testify on the exact requirements in state law. In the case of my student, there was no such ability to provide such notice, right? So this was a case of unexpected termination of coverage, and it was based on her father passing. And so there was no opportunity really to provide 90-day prior notice, but I do believe that there are some requirements in existing law that have that opportunity.
Okay. Any other questions? Seeing none, thank you so much for bringing this bill to our committee. And again, thank you so much for being with us today. We're going to call now Marie Grant, who is the Maryland Insurance Administration Commissioner, Acting Commissioner, and she has an info.
Yeah, thank you so much, Madam Chair, Madam Vice Chair, committee members here. Information only, but offered a couple of thoughts, which it sounds like actually the carriers may have had similar thoughts too. So you know, happy to work with the sponsor on amendments, and I think it sounds like we're there. We had two suggestions from the technical perspective. The first is allowing for clarification on what that additional health benefit information that's included in the notice might be, and I think we're on our way for language there. And then the second issue is really around the manner of delivery. Sometimes certified mail can actually be really challenging for consumers because no one's home anymore to sign things, and that can delay receipt. So we had a request to consider alignment with other methods of first-class mail delivery that we have in the insurance article. So happy to answer any questions, but those were our technical perspectives, and appreciate the sponsors' work with us on the bill. Yeah.
Matt, can you come up, please? Thank you. Because I think we're on the same page more or less.
Yeah. Yeah.
Madam Chair, I'd like to align all my comments with Commissioner Grant.
So that being said, are there any questions? All right, seeing none, I'd like to make a request of you. Please, will you work with the lawyer for this subject matter is Ms. Lisa Simpson. And can you do so before it goes to subcommittee? I will send it to subcommittee, but I'd like you to make it easy for her and send her the language. And then it'll go to subcommittee, okay?
Yeah, Madam Chair, I also just want to say thank you to Delegate Shetty for having a conversation with us this past week about our concerns with the bill and addressing them. And I think we have conceptual approaches that should get us to a absolute yes.
That would be wonderful. Well, thank you for working with the amazing sponsor and this committee, okay?
Thank you very much,
And actually, this will conclude the bill hearing on House Bill 936. Let's move on to House Bill 974, Delegate Shetty, Health Insurance Preventive Service Enforcement Authority. I believe you do have Lance Kilpatrick, Donna Kaufman, and Marie Grant. If you're here, will you come up and keep the sponsor company, please?
I always like to be in good company. That's why I like being in this committee room. So thank you for welcoming me back to the table. All right. Thank you, Madam Chair, Madam Vice Chair, esteemed members of the Health and Government Operations Committee. For the record, again, my name is still Emily Shetty, and I thank you for the opportunity to testify in support of House Bill 974. So this bill would codify the preventive care protections of the Affordable Care Act into Maryland state law. So in the 10 years since the Affordable Care Act was fully implemented, over 1.5 million Marylanders have been able to access coverage for at least one free preventive health care service, such as immunizations, annual wellness checks, cancer screenings, or birth control. More than just having access, Marylanders have also come to rely on the free preventive services as vital health care coverage, because that's what it is. For example, early detection of certain cancers and other chronic diseases through screening can reduce mortality from these conditions by 15 to 20%. Moreover, preventive care saves both patients and the state healthcare costs. One study from Trust for America's Health shows that for every single dollar that we spend on preventive healthcare, we save $6 in healthcare costs. But money isn't all we care about in this committee, right? That's what you guys send to us appropriators. As somebody with a chronic autoimmune disorder, access to preventive services has unequivocally helped me keep my condition in remission. I am able to get regular labs done. I'm able to get regular check-ins with my primary care provider, and I'm able to get needed screenings to make sure that my condition and other related conditions and side effects of some of my treatments remain in remission and in check. Being in remission means that I stay out of the hospital. It allows me to continue to do this meaningful work alongside each and every one of you, and to be a present mother to my 9-year-old son. And it is also saving our state a lot of money as well. So today, federal actions threaten access to some of these preventive care options here in Maryland. And so just like this body did in 2020, when codifying incredibly important provisions of the Affordable Care Act into state law, including our essential health benefits provisions, we need to shore up this protection for preventive care in our state code. This bill guarantees that Maryland will continue to make healthcare decisions based on evidence, and it also ensures that preventive services will continue to save lives. I just want to point out that I have an amendment that's been drafted at the request of the healthcare unit within the AG's office. They are favorable with amendment. I took those amendments and thought, these are amazing. Let's go ahead and get them sent in. And so we have sponsor amendments fresh off the press. I think if we've not yet sent them to you, they are on their way to your council's desk. So I ask this committee's favorable consideration, please, of HB 974 to continue to protect Maryland's access to necessary preventive care. Thank you so much.
And thank you. I am glad that Ms. Williams, I spoke to her late last night, and I told her what she needed to do and that this was an important bill.
Thank you.
So thank you for working with her.
Of course.
Thank you. Next, please.
Who would like to go?
Oh, okay. Sure. Thanks, Delegate Shetty. Madam Chair, Madam Vice Chair, committee members, Marie Grant on behalf of the Maryland Insurance Administration here in support of this bill. Also aware of the amendments submitted by the AG. I think I would sort of characterize them as belt and suspenders amendments, really just trying to make sure we get the language just right to ensure that we're protecting zero cost coverage for these important services in Maryland law. And happy to be here in support and answer any questions.
Thank you. Next, please.
Madam Chair, Madam Vice Chair, members of the committee, for the record, my name is Lance Kilpatrick. I'm the Maryland Government Relations Director for the American Cancer Society Cancer Action Network. In 2025, we anticipate that 30,720 Marylanders will hear the words, "You have cancer," and sadly, almost 11,000 of them will not survive that diagnosis. Preventive care services recommended by the United States Preventive Services Task Force are crucial for maintaining strong public health, and impeding patients' access to preventive care would have an immediate and devastating impact. The Affordable Care Act preventive services provision requiring private insurers cover task force recommended services without cost sharing increases patients' ability to receive care that prevent disease outright, identify conditions early, improve survival rates, and reduce the physical and financial burdens of treating severe illnesses. Detecting severe diseases early allows for less invasive, more effective, and lower cost treatment options, and substantially improves patient outcomes. The ACA's preventive care requirements have functioned for more than 10 years now, enabling millions of Americans to obtain preventive care and improving utilization of those vital services. Current litigation threatens to erode more than a decade of progress reducing cancer deaths and suffering. Having guaranteed no-cost coverage of proven preventive and screening devices and services like those for breast, colorectal, cervical, and lung cancer has enabled more people to get timely, life-saving screenings without facing potentially unaffordable out-of-pocket costs. Research has repeatedly shown the benefit of these screenings in both lives and dollars saved, and before the passage of the ACA, high costs and unclear coverage were repeatedly cited among the top reasons people delayed or skipped screenings. We can't risk returning to a system wherein every individual has to interpret their complex insurance plans to determine if a recommended mammogram will be covered or to determine how much the colonoscopy may cost. So with that, I urge a favorable report on HB 974. Thank you.
Thank you very much. Next, please.
Good afternoon again. For the record, Dana Kaufman here on behalf of MedChi. We are in strong support of this bill for all of the reasons that have already been stated, and given the time, I'm just going to say me too.
And we love that here, so we're going to open it up right away.
Remember
to
that.
questions. We're going to jump on that. Are there any questions? Vice Chair Collison.
Thank you, Madam Chair, and thank you, Delegate Shetty. You've done a fabulous job with this bill. Have you had a chance to look at the HGAU's letter?
Yes, ma'am, Madam Vice Chair, really appreciate the question. We did review the HGAU's letter. I took the suggested amendments that they offered. I sent them to the amendments office. We have them back they're ready. MIA has indicated support, has characterized it as belts and suspenders language, just to make sure we have all of our T's crossed and I's dotted. They are hopefully already in your council's inbox, but if not, I will make sure we get them there.
Okay.
Thank you.
Thank
We
you. I
got
look
them.
forward to it.
We got them.
Perfect.
Thank you.
Thank you.
Any other questions? Seeing none? Any questions from anyone? No? All right. This actually concludes the bill hearing on House Bill 974.
Thank you.
Thank you for your work. We appreciate you. And now we're on to the last bill of the day, House Bill 1007, Delegate Wells. Is she here? Does she have a panel? Can you see if can she be called? Delegate Miller? Do you know where Delegate Wells is?
Yes, I'm here for her.
Okay.
Yes.
All right. Thank you for letting us know. We were about to call her. Okay. So this is House Bill 1007, Genetic Testing, Prohibition on Disability, Life, and Long-Term Care Insurance, Genetic Testing Protection Act. Tell us who you are.
Yes. Hello, Chair Pena-Melnick, Vice Chair Cullison, members of the committee. For the record, my name is Matt Kramer, and I'm Delegate Welsh Chief of Staff, and I'm here to present House Bill 1007.
Welcome.
Thank you. House Bill 1007, the Genetic Testing Protection Act, would prohibit an insurer that offers, issues, or delivers a life insurance, long-term care insurance, or disability insurance policy from taking adverse actions related to genetic testing against an applicant or insured. There we go. All right. The bill does not prohibit an insurer from accessing an applicant's medical records as part of the application process or considering a medical diagnosis included in an individual's medical record, even if the diagnosis was based on the results of a genetic test. In July of 2021, my family was given the news that my mom, Ann Kramer, was diagnosed with ALS. For those unfamiliar, ALS is a fatal disease with no known cause, no cure, and limited treatment options. ALS gradually rips away every piece of what makes you, you. It slowly takes away your ability to walk and independence. It takes away your ability to talk with your friends, your loved ones. It takes away your ability to eat and drink the family meals you love, and it ultimately takes you away from this earth. This is exactly what happened with my family. My mom was a devout Christian and lifelong Episcopalian. She was proud to serve as the director of Christian education at All Saints Episcopal Church in Frederick. Her life was dedicated in service to children and her faith. She was a firm believer that no child or person should ever be made to suffer, and that we all have a responsibility to protect those most vulnerable among us. And while I do not pretend to know the complete inner workings of the MGA, I do have to hold on to the hope that we're able to accomplish amazing things here that keep the most vulnerable at the heart. But where I begin to lose that hope is that while there have been many good faith attempts to address the concerns of the opposition of this bill, they simply offered they fundamentally could not get to neutrality on this bill because it would hurt their bottom line. To be clear, this will not bankrupt them. This will not make them less profitable as a multi-billion-dollar industry. They claim this will just hurt their bottom line. Furthermore, they will tell you that because there are no MIA complaints that this is a non-issue here. But while I watched my mom lose her ability to walk, I was not thinking of MIA forms. While my mom lost her ability to talk to me, I was not thinking about MIA forms. While I watched my mom become smaller and weaker because she could no longer swallow her food, I did not think of MIA forms. And while I watched my mom die in my arms while she was looking at me, I did not think of MIA forms. While all of this is happening, each one of my brothers and I now had to selfishly wonder if this was a familial case of ALS. Do we have this gene? Is this what our end of life could look like? Unfortunately, because of the legal discrimination around genetic testing, no one in my family would go get this test in fear of not being able to get the coverage we would potentially need. The only piece of this that makes our family lucky is since my mom was already denied coverage, she was able to take the genetic test to find out her case of ALS was environmental and would not pass down to her children. And still, this test costs thousands of dollars. My family is lucky and fortunate enough to be in a position that we could handle the cost, but other families are not. Lastly, the opposition will tell you they need a complete look at someone's health to determine the best policy for them. But what we know happens is the information will be used against you. So you're caught between getting the genetic predisposition knowledge to be prepared for what your life could turn to be, and then having that used against you. I sincerely hope we can take a strong look at this bill, because to say we cannot pass it because of the profitability of a business or the lack of MIA complaints does not help those who are being crushed under the economic hardships of today, especially during the most difficult time in their life. With this, I and Delegate Wells ask for a favorable report on House Bill 1007.
Thank you for being with us today and for standing in for Delegate Wells. And thank you for sharing your story about your mom, and I'm so sorry that you lost her.
Thank you.
Okay, on behalf of the committee, we're very sorry.
Thank you.
Who would you like to go next?
I can go. Thank you. Chair Pena-Melnick, Vice Chair Cullison, and members of the committee, thank you for the opportunity to speak today. My name is Lindsay Jack, and I'm the Managing Director of Advocacy at the ALS Association. I'm here to urge your support for HB 1007. Right now, people hesitate to get genetic tests, not because they don't want to know their health risks, but because they fear that it will make insurance coverage unaffordable or even unavailable. This bill encourages preventative health care, protects consumers from unfair insurance practices, and strengthens public trust in medical research. Let's be clear about what this bill does. It prevents insurers from using genetic test results alone to determine coverage or pricing. It allows people to get the genetic information they need to make informed health decisions without the fear of financial consequences. It ensures fairness. People should be assessed based on their actual medical conditions, not what might happen in the future. And just as importantly, this is what the bill does not do. It does not stop insurers from reviewing medical records, existing diagnosis, and family history. It does not disrupt the insurance industry. Florida passed a similar law in 2020, and nearly 5 years later, their insurance market remains strong. It does not lead to widespread fraud or adverse selection. People already make insurance choices based on family history. This bill simply ensures fairness in that process. Opponents will tell you that this bill hides critical information from insurers. That is not true. Insurers have never required genetic testing to issue policies, nor do they need it to run a successful business. The idea that they suddenly need this data is misleading. The truth is, genetic discrimination deters people from seeking life-saving medical information, and that is an unacceptable outcome. I urge a favorable report. Thank you.
Yeah, who is next?
Thank you, Madam Chair, Madam Vice Chair, members of the committee. For the record, I'm Patrick Hogan with Cornerstone Government Affairs, representing the ALS Association, which is leading a coalition of 16 organizations committed to improving health outcomes in Maryland, and is in strong support of House Bill 1007. We submitted written testimony, and I would encourage the committee to take a look at it, including the many logos of some very impactful health advocacy organizations that are on there. Additionally, Madam Chair, when we met with you on this bill during the interim, you suggested we reach out to Johns Hopkins, so I wanted to highlight that they submitted written testimony in support as well. I just want to highlight a few key points from that written testimony. Genetic screening identifies DNA mutations that may indicate disease risk, allowing individuals to take proactive steps for early detection and prevention. This leads to better health, longer lives, and lower healthcare costs. One of the biggest barriers to genetic testing is fear that results could affect life, disability, or long-term care insurance. This isn't just a possibility, it's a reality. These organizations that have signed on to this letter have witnessed this discrimination firsthand with their patients and their families. Concerns about insurance companies accessing genetic information discourages people from getting tested despite its proven benefits in early disease detection and prevention. House Bill 1007 eliminates this barrier by ensuring genetic information cannot be used to deny insurance coverage. Beyond personal health, genetic testing drives medical research and advances treatments. Protecting privacy and preventing genetic discrimination will encourage participation in research and clinical trials, ultimately leading to better health care across the board. This growing coalition supports this bill because it will allow Marylanders to make healthcare decisions without fear of financial consequences. For those reasons, we ask for a favorable report.
Chairwoman and members of the committee, thank you for the opportunity to provide testimony in support of House Bill 1007. My name is Brian Schaefer, and I am the proud father of 7 amazing children. I live in Bel Air, Maryland. ALS has taken 4 members of my family, my father, sister, aunt, and grandmother. In 2 of those cases, I witnessed firsthand as they gradually lost all their physical abilities before ultimately losing their lives. I watched my father struggle to continue providing for his family while barely able to lift his arms. I saw him nearly choke to death at our kitchen table because he could no longer swallow. I watched my sister, a devoted teacher, use a microphone in her classroom so she could continue teaching for as long as possible before being forced to leave the job she loved. Eventually, her condition declined to the point where I had to feed her, something no brother should ever have to do for his sister. ALS is a cruel, horrific disease that I would not wish on my worst enemy. I have tested positive for one of the ALS-related genes. Fortunately, I am under close monitoring. If I do begin to show symptoms, early detection will be critical to assessing any available treatments. With ALS, early diagnosis and intervention can make all the difference. Genetic testing is essential, especially for those with a family history of ALS. It is one of the only ways to have a fighting chance against this disease. Yet under current law, if any of my children undergo genetic testing and test positive for any ALS-related gene, they can face discrimination and be denied life insurance coverage. Because of our family history, my children are already at risk of facing higher insurance rates regardless of whether they ever develop ALS. Denying them coverage based on a genetic test result only adds to this unfair burden. Life insurance companies have been around for centuries. They have survived economic downturns, wars, and pandemics. Like any other successful business, they adapt to changing conditions. Passing this bill will not ruin the life insurance industry. Please do not let the fear of being denied life insurance deter my children or anyone else at risk from getting tested. Thank you.
Okay. I'm going to open it up for questions now from this panel. I see Delegate Rosenberg first.
Question for the first witness and then to the last witness, if I can. When Cal Ripken broke Lou Gehrig's record, were you and your mother paying attention?
I have to be completely honest with you. I know nothing about any sport. I know, a little shocking, but no.
Well, if I may, the record that Ripken broke was by held by Lou Gehrig, whose career ended when he got ALS. And living in Bel Air, you must have known that.
Oh, yeah. I was very familiar with it and watched it very closely.
And were people in your family sick already at that time?
Back in 95, no, at that time they were not, thankfully.
Thank you, Madam Chair.
All right, any other questions? I see, if I may, I have a little bit of, I put my X's here and the wrong names. Lisa Peabody's in the back. Okay, Aaron, you're Aaron? Okay, it's okay. But let me ask them a question. Hold on a minute. There is some confusion as to how many states have passed this bill. Can you tell us how many states have passed this bill?
The bill that has passed that's nearly identical to ours is Florida.
And how long has theirs been in effect?
It was enacted in 2021.
2021. And do you know how is the industry doing since it passed?
Their market is strong right now. There is data from NAIC, the National Association of Insurance Commissioners, that points to very minimal increases that we've seen year over year. The data we have is from 2021 to 2022, 2022 to 2023. It's been 2 to 1% increase each year. So very, very minimal impact.
And it passed in Florida. Any other states?
There's been other states that have passed similar legislation, but pertaining to different types of insurances. So whether that would be disability or long-term care insurance are typically the main insurances that have passed in other states, and there's a patchwork of about 16 states that have passed something similar. But most identical to our bill, Florida is the one that has passed. There's about 5 states right now that are pending similar legislation and is moving through their legislatures right now.
Okay. And did you read the letter from the Maryland Insurance Administration?
We will, Madam Chair.
Okay, because their letter of information is pretty detailed. And you know what we'll do, we'll make sure that you get it. If you could go to my committee, make sure that you get it, okay? So there's just a lot of different issues that they brought up that need to be addressed, all right? With the definitions not being consistent across the code as well. I'll discuss my thoughts in a minute. Let me call the next. Are there any other questions? Seeing none. Okay. Seeing none, I will call the rest, okay?
Thank you, Madam Chair.
I have Lisa Peabody and Aaron Wright. Actually, you know what? Because that was favorable, let me call an unfavorable panel, and then you can come after that one, okay? Because you're favorable.
Yeah.
Let me call an unfavorable panel, all right? I'm going to call Vincent Ryan, Paul Quatara, and Matt Chantilano. And I have, since they were 4, let's be fair, can you bring the virtual unfavorable up, please? Okay. Can't say we're not fair here. Go ahead.
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 1007. I would like to start by saying that ALS is truly awful, and we all hope for a cure. The stories that we heard are heartbreaking, and we can never endorse anything but trying to find a way out of that sort of challenge and that hell. But we need to relay that life insurance is fundamentally different than health insurance. We see a lot of health insurance bills in here, not as many life insurance. The two products are completely different. Life insurers get one bite at the apple. We build a rate to you. It is not guaranteed issue community rating like health insurance. It is specifically built to you. And that policy lasts for decades. It can never, ever be canceled. Nobody ever requires a genetic test. And there's no raising or rates on health, like in health insurance. We don't do rate review on a yearly basis for your life insurance policy. Once you have that policy, you have it for your lifetime, and that policy can last decades and decades and decades. This is also a voluntary product. It can never, ever be canceled. This bill has a chance to upset the entire marketplace. And while we sympathize with the proponents for sure, there are very serious consequences to this policy. Life insurers just want to make sure that the majority of Marylanders that buy life insurance products, and many of whom buy them as their sole form of retirement or savings, over 50% of Marylanders use life insurance as their sole portion of retirement. We have to keep them affordable. So I have brought with me today 2 experts that I think should be able to help answer any of your questions. Vince Ryan from the American Council of Life Insurance, and Dr. Paul to my right, who is a medical director with one of the company, who was formerly a primary care physician before he went over to New York Life. And I hope they can answer all your questions. But unfortunately, we have to be opposed to House Bill 1007. Thank you very much.
All right. Welcome. Will you give us your testimony, please?
Yes. Thank you, Madam Chair, Madam Vice Chair, members of the committee. Vince Ryan appearing on behalf of the American Council of Life Insurers. And just to echo Matt's sentiments, we do sympathize with the concerns raised by the proponents of this legislation, but again, also ask that this committee give it an unfavorable report for the concerns that Matt and then I will raise in my testimony. I want to clarify a couple of things. Since 2019, there have been over 40 bills introduced related to genetic testing and life insurance, but of those bills, no state has enacted an outright prohibition on a life insurer's ability to consider genetic test results, clinical genetic test results, and information in underwriting. 16 states may have taken action on this, but no state has taken action that this bill would if it were to pass this body. If enacted, this bill would be the first in the country to deny life insurers access to test information that may be predictive of risk. Unlike health insurers, we only have one opportunity to evaluate a person's risk before issuing the policy. And we need to be able to forecast 20, 30, 40, 50 years out from the date of issuance of the policy, because we cannot cancel and we cannot adjust premiums because of a change in a person's health or subsequent test results. That's simply not how life insurance operates. And so it's crucial for us to have access to a complete and accurate medical record. We don't view these test results as exceptional or separate and apart from the routine medical file. And in fact, they are weighed against a whole host of factors and a holistic analysis and evaluation of that individual applicant. And in fact, in many cases, consideration of a test contained in a medical record can be a benefit. And so I'll finish by saying that contrary to what has been said here today, life insurance availability is competitive and accessible. And that what we're asking for today is simple. It only makes sense that a life insurance company, if we're going to make a long-term promise for 50 years, that we need to know an applicant's true health condition at the time of issuance. So thank you very much for the opportunity to be here with you today, and I look forward to your questions.
Next, please, and thank you for being with us. Next.
Good afternoon, Madam Chairwoman and committee members. My name is Dr. Paul Quattararo, and I am the Chief Medical Director at the New York Life Insurance Company. Prior to working at New York Life, I practiced general internal medicine and served as the medical director of my local hospice. I appreciate and am very empathetic towards the individuals and families who suffer with ALS and other debilitating conditions. Unfortunately, today I am here to speak in opposition to House Bill 1007. This bill undermines our ability to maintain a sacred promise, a promise to our policyholders that we will pay their beneficiaries upon their passing. In order to keep our promise, we must be able to accurately assess the true mortality of our applicants. We can fulfill this promise only if we have complete medical information at the time of application. We need to be able to see all the information, including genetic information, in a person's medical record. I can tell you that we do not require genetic testing as part of the application process, and we do not ask if the applicant has undergone genetic testing. However, if a person's physician has used genetic information to evaluate that patient, we believe we are obliged to review the medical record to understand the role of the genetic information in that person's care. This situation is similar to that of a patient whose physician evaluates their risk of heart disease using a treadmill stress test. We need to know what the treadmill stress test showed. And just as we insure some people with heart problems, so too we do insure people who have abnormal genetic tests. We are asking for a level playing field. Our goal is to insure as many people as possible. This bill would negatively impact our products because we would not be able to collect sufficient premium to cover the claims of people whose medical history is not fully disclosed. We want to sell more insurance, not less. Thank you for your time. I'm happy to answer your questions.
Thank you. There's someone else that you wanted virtually, right?
Correct.
So I will go ahead and allow her, and then we'll open it up for questions, okay? Good afternoon. How are you, Ms. Craver? How are you?
Hi, I'm fine, thank you. And thanks for the opportunity to testify. I'm Jan Graber, Senior Actuary at the ACLI, and I'm testifying in opposition to House Bill 1007. I also want to stress that life insurance is fundamentally different than other types of insurance like health insurance or P&C. Our products are voluntary, so people choose how much coverage to buy and when to buy it. And the biggest threat to any voluntary product is anti-selection, where individuals wait until they have reason to believe they're at a greater risk before purchasing coverage. So imagine a scenario where someone discovers through genetic testing that they have a condition that will significantly impact their mortality. And naturally, they would want to protect their family, and they may decide to buy far more coverage than originally planned. Second, underwriting only occurs at the time of application, before the policy is issued. So once the policy is issued, we can't cancel it, we can't adjust the premiums, we can't deny future claims based on changes in the policyholder's health. Our goal is to insure as many policies as possible, and we can only do that when premiums accurately reflect the underlying risk. Otherwise, we would be creating a situation similar to someone waiting until their house is on fire to buy homeowners insurance. Life insurance only works when people purchase coverage before they need it and not in reaction to information that impacts when or how much coverage to buy. And finally, it's important to recognize that there are already options in the market for those concerned about the use of genetic information in underwriting. If a consumer doesn't want to share this information, other options are currently available, such as group insurance through their employer or guaranteed issue coverage with little or no underwriting. So at the heart of this issue is information symmetry between the insurer and the applicant, meaning both parties have access to the same relevant information at the time of issues. And if we're required to ignore that information, it creates an uneven playing field and drives up the cost for everyone. Thank you for your time and consideration. I'm happy to answer any questions.
Thank you for being with us. I'm going to open it up for questions now, okay? Are there any questions? First, Delegate Bagnall, followed by Delegate Hill.
Thank you, Madam Chair. And thank you to the panel. We've heard this bill before, so I want to give a little context to my question because the last speaker made the analogy of a house on fire before you're getting coverage. But if we look at ALS, a familial connection isn't necessarily definitive. It's about 40% or 60% versus 40% environmental. If we look at genetic markers, they are not definitive that you will develop ALS. So in our current environment, how do you weigh a genetic finding against your actuaries in your underwriting currently? Like how is that considered?
Thank you for your question. I think that is at the crux of this discussion. You are addressing something called penetrance of a genetic abnormality, meaning if somebody has a genetic abnormality, what is the likelihood they will get that disease? And if we're talking about a life insurance product where mortality is the end of that disease process, it's not just will they get the disease, it's will they pass away from that disease. So penetrance is a way of looking at that, and you say, it's kind of like a weather forecast. The weatherman says, well, a week ago, we thought we were going to have 15 inches of snow here, right? Things changed because they were using models and they made a prediction that there would be 15 inches of snow. But the weatherman might say, okay, it's a big county, it's a big state. Maybe the 15 inches of snow will fall inland, and by the water, they'll only get 3 inches. They're guessing. Penetrance is an estimate, much like the weatherman's estimate, 100% chance of rain today. Well, is that just in one corner of the county, or will the whole county have rain all day? Will there be only rain for 3 hours? That's a 100% chance. So when we talk about penetrance with a genetic abnormality, we have to say, what's the likelihood if the test is abnormal, someone will get the disease and ultimately pass away from that? I mentioned in my presentation that we insure people with genetic abnormalities. I'll speak to BRCA. And I'm going to give you some proprietary information. I know there are limits on how much I can do that in a public setting. But if somebody's found to have BRCA present in their genetic makeup, my company will still insure you. But not everybody with BRCA. What we're looking for is if, in the medical record, there's a discussion that this person was found to have BRCA, and that the applicant for insurance, the patient, and the doctor had a serious conversation, and that conversation came up with a surveillance plan that will ultimately result in the prolongation of the life of that person. And furthermore, that the applicant is adhering to that surveillance plan. There's no guarantee that that surveillance plan is going to save their life, but it's going to tip the odds in their favor a lot. We insure that person. Are they going to get our best rates? No. Will they get a very good rate? Yes. Does that help?
It does. If I could have a follow-up, Madam Chair. Thank you. And I appreciate all of that. But the testimony that we've heard is centered around ALS. So I do actually want to center this question around that. Because again, we had the analogy of a house on fire and getting insurance. So my question is, following that analogy, would a genetic marker for ALS be a house on fire or missing sprinklers? Like, where are we in this analogy? How much does it weigh into that consideration?
I appreciate your desire to be that specific. However, in prior years in this very room, I believe the opposing argument has been that this will help out people beyond ALS. And there have been people who have testified who are trying to address many diseases and many cancers. So I think it would be unnecessary to answer for ALS. What I will do is I will spring to the other end of the penetrance spectrum and take us to Huntington's disease, where penetrance is essentially 100%. And if somebody has a gene that's abnormal for Huntington's disease, you can be certain that they are going to get Huntington's disease and die prematurely. And depending on which of the products my company sells, and we sell many, many different types of products. Some of them are life insurance, and there are other, like long-term care and disability. But we sell group insurance, we sell employer insurance, we sell fully underwritten products. Based upon the type of underwriting that occurs and the type of product, the price differs. And if somebody tells us that they have a family history of Huntington's disease, we will ask for medical records, depending on the product. And what we're hoping to find in those medical records is that they have come up with a negative genetic test. And this bill would prevent us from looking at that negative test. This bill would require that somebody with a family history of Huntington's disease be declined, whereas I would like to see that they've been tested and they can be insured because their test is negative. Does that help?
And if I could, can I add
No, you're only, someone can ask you a question. So you're not allowed to answer the same question, different panelists, okay? And we still have a meeting after this. Delegate Hill.
Thank you, Madam Chair, and thank you all for your testimony today. I'm going to, you know what, I'll direct the question to, I can't read the name.
Jan Graber.
Right, since I was going to take it to you, Doctor, but we'll go this way. Yeah, I think that this is, for me, the underlying issue. Life insurers do pretty good underwriting without access to genetic testing. You don't require genetic testing. We want people to get genetic testing so that they can do the things so they can live healthier, longer lives, which for health insurers would be a priority, may not be a priority because you're going to pay sooner or later anyway, right? That's your product, right?
We all go.
So the problem is I'm not clear why you're doing so well without this information, but you seem to feel that having access to the information when it's available is critical to your success. So I'm going to direct the question to
Jan.
Okay, so that you can have an opportunity to answer the previous question.
Thank you. I think it's important to remember that it's not the genetic testing that we are opposed to. It's that asymmetry of information. And underwriting is a holistic evaluation of the health of things that impact an applicant's mortality or morbidity. So it's really not based on, it's rarely based on just one factor. So we'll look at, things that the applicant is doing, lifestyle factors. Are they taking medication? Are they managing their condition? And so it's not going to be based on just one factor. Does that help?
Well, I know that wasn't the question. The question is, you're doing pretty well now. What you're saying is you don't want the patients to have information that not only could affect their health, but could affect whether they purchase a product or how much they purchase if you don't have access to the information too. And my question is, you're doing pretty well without that information. So why are we to believe that not having that information accessible to you, if a patient chooses to have it, is going to have devastating effects on the marketplace, as one of the other panelists has testified?
Right, and so genetic testing is evolving, and so it's more precise, and all we're saying is we want to have access to the same information that the applicant has access to. So if they've had a genetic test, we want to know the results of that. If they have not had a genetic test, right, we would not consider.
It's okay. I understand that was the question. That just wasn't responsive to mine, but I thank you. Thank you, Madam Chair.
Delegate Kerr.
Thank you, Madam Chair. Doctor, I have a question that's kind of the opposite of Delegate Bagnall's. If this bill becomes law, how would it affect someone who comes from a family with a history of genetic mutation? They get the genetic test and it comes up negative.
Thank you for your question, Delegate Kerr. That person would have no reason to be adversely viewed in any way, shape, or form. If I may continue, though, I think, Dr. Hill, Delegate Hill, there's a piece of the puzzle that we can discuss, and that is that even though we don't ask for genetic tests, that doesn't mean we don't need them. When I oversee a team of physicians who work with a team of underwriters who handle large volumes
I'm going
of
to
cases.
allow it, but we can't do that.
I can't do what? I'm sorry.
Because, yeah, she answered it already, right? And we have to keep going because there are more witnesses behind you, okay? You can go ahead and finish your thought, but please.
Concise.
Okay, it's okay.
I'll be concise.
All right?
Thank you very much, Chairwoman.
Thank you.
We rely on the clinician who's with the patient in the exam room and their judgment. We do not presume that genetic testing is useful as a screening tool for a healthy population who generally applies for life insurance. And if somebody shows up at their doctor with a complaint, a symptom, or a sign, and that doctor feels that genetic testing is necessary, we would like access to that. That's really what we're saying. I'm sorry, I misunderstood then.
It's okay. All right.
I misunderstood, I'm sorry, thank you.
Delegate Taveras.
Thank you. I'm just curious why everybody feels that the bottom's going to drop out when in Florida it's been already passed and nothing has really happened.
Okay. Oh, you go. No.
Thank you for your question, Delegate. If I understand the question, you want to know why insurers are concerned about what the proponents have alleged is our concern about our bottom line if Florida.
No, the market. The market hasn't dropped. Everybody's still buying.
So Jan, as well as my colleague over here, can provide a little bit more academic detail. But what I would say about the law that was written in Florida is that that law is only 5 years old. that law applies prospectively to policies that are issued on or after the effective date of that law. So we won't actually know necessarily the true impact or the outcome of that law on the Florida marketplace for 10, 20 years down the line. What we do know, however, is that when laws do remove tools from insurers' proverbial toolbox, if you will, is that limits our ability to accurately assess and underwrite risk. So to characterize the Florida law as having absolutely no impact or negligible impact on the marketplace, in our view, is not necessarily an accurate statement.
So let me follow up on her question. So the law has been now in effect for 5 years. Do you keep track of your payouts?
Speaking on behalf of the American Council of Life Insurers, as a trade association, we don't keep track of individual carrier claims. I can, again, refer you to my colleague over here who could speak to possibly.
So whoever knows this answer, do these companies, your company that you represent, do they keep tracks of the payouts every year? Do they keep track of how many payouts they have had?
Yes, we keep track of claims
Okay.
data. Yes.
And so the claim data in Florida for the last 5 years, what has it shown?
I'm not qualified to answer that.
Okay, we need to get that answer.
I'm not the right guy.
Okay, we need to get that answer. Okay, Delegate Johnson.
Thank you, Madam Chair. And following up on your question, I see that folks with serious ALS live 2 to 5 years. However, some do live longer. So this bill has been in effect in Florida for 5 years. So surely it would have captured some of those ALS patients. And they really do not see any significant difference. So can you speak to that?
I would assume it would capture individuals with ALS, but again, that law in Florida doesn't apply specifically to ALS genetic mutations or genetic tests. That applies broadly to literally every genetic test and genetic mutation. So I can't speak specifically to ALS. I would just reiterate that, again, it's been in effect for 5 years, but these products are long-term products. So we won't know the exact impact of that law on the marketplace, like I said, until 10, 20 years down the line.
Madam Chair, for some people, it's not a long-term product, and it does include ALS, the Florida law. So they would be included in there. So, and they've seen no significant difference. So why should we think it's going to be totally different here?
Delegate Johnson, I appreciate the question, and I think that we're getting a little bit away from what I feel is the overall concern of the bill, is that it's not like health insurance. If we get it wrong, we can't come back and fix it, right? So what has happened in Florida is a concern in the long-term solvency, and to that, I know you have a letter in your file from the MIA, but I printed it, but I had the highlighted one from last year, from January, from Associate Commissioner Cooney, and he specifically talks about the long-term sort of financial solvency, where he says, given that for these types of long-duration insurance policies, the applicant's health status, as well as their individual and family health history together, are not only permissible considerations during writing, but are often critical considerations in deciding whether to insure the applicant, and if so, what to charge for that insurance. From the standpoint of fiscal responsibility and solvency, it is imperative that carriers price these products correctly at the outset to assure that the amount of premium collected over the life of the policy will be sufficient to cover the claims. I'm not worried about right now. I don't think these folks are worried about right now. We're worried about the long term. And we're not saying don't take it. Nobody's ever telling you not to take a genetic test. Nobody's ever telling you that you shouldn't go out and try to address those health concerns early. But if you've had them, we would just like to know. And it goes into a bucket of information that is built to make the product for you, Delegate Johnson. We want to know about you. We don't want to know about my old friends on this side of the room. We need to know about you to get you the best possible priced product. And if you do have one of these factors that is going to make your policy more expensive, we would suggest there are all kinds of life insurance products. You can get on the internet right now with no underwriting and get a life insurance policy in about 15 minutes. There are group policies you get through your employer. This is a voluntary product, this type of life insurance product that has the possibility to upset the entire marketplace, and why we're opposed to this particular bill.
The current letter we have from MIA is not the one that you read.
I would be happy to provide this letter, which I have still highlighted. I printed it out, but I had this one in my file, and I thought that was a really important portion to bring up for the consideration of the committee.
Just want to make the record clear.
Sure.
That what we have in front of us is very different as well. And if you could give us that one.
Sure.
That would be great as well. Delegate Bandari.
Thank you, Madam Chair. As we talk about the Florida law that was enacted in 2020, and you guys highlighted the negative outcomes if we enact this law. But when I do the research, there not has been anything materialized when in Florida the market remains stable. In this light, if Florida can protect its residents from such genetic discrimination without disruption of the industry, why should Marylander be denied the same protection?
Thank you for your question. As we've heard, we think it's too early to see an effect in Florida. Furthermore, I'll refer back to something I said earlier, which is this law will impact a wide range of diseases. And as I said in my statement, why would we treat genetics differently than we treat other types of testing? We've heard the phrase genetic exceptionalism. Why should we treat genetic testing different than cardiac testing, testing for the heart and heart diseases, or testing for the lungs or the liver? This is a difficult path if you carve out one whole set of diagnostic testing. As we've heard, this is a field that's evolving rapidly and could become a mainstay of medical treatment well beyond life-threatening diseases. It could become a very important preventive measure. And we've even heard from our opponents that they hope that there will be preventive opportunities based upon genetic testing. So if we limit the access to the genetic information, we are carving out one group of tests separate from all others that have potential to be preventive. Not to mention that I earlier gave examples with BRCA, for example, where we are making offers, and they're good offers. They're very reasonable offers. So we need to see the genetic tests, and we need to see that people are aware of those results and are taking the right action to them in order to make good offers. Carving this out just puts a big, heavy, wet blanket on it.
Madam Chair, if I may.
No.
I mean, the same logic and the fear were raised by the industry when I watched the testimony when they passed the bill, but nothing happened.
Well, like I say, I don't have the numbers. I think it's a little early, but I could tell you on a day-to-day basis. For example, early on, I saw a case of a man who was in his 40s who had some bleeding from his colon. And he went to the doctor, and the doctor said, you need to have a colonoscopy. So he went to the gastroenterologist, and the gastroenterologist agreed. You need to have a colonoscopy. The man decided he didn't want to go. Now, the man was also told to get genetic testing. He didn't do that either. In Florida, if it was the genetic test had, let me rephrase that. If the genetic test had shown that he had a hereditary disease and he had bleeding and he had not gone for a colonoscopy, we would not have insured him. If he had gone for the colonoscopy and it was perfectly normal, we would have insured him. The genetic test would have been an important factor in the decision of at what level of premium we would insure him if the colonoscopy is normal. Because he didn't go for his colonoscopy, we did not make an offer. I mean, he was bleeding, didn't go for a colonoscopy. Where was the genetic test in that? That could have helped him to decide that he should have gotten the colonoscopy if it was abnormal. He decided not to do any of that. That's his choice. But it left us in a total dark space. So I look at a case like that and I say, what would have happened if we needed to use the Florida law? I would have loved to have given this man insurance if he went for a colonoscopy and his genetic test was negative. As it is, we like to place insurance. We couldn't place insurance. And because of his decisions, he was left without care. I don't know what happened, obviously, because he didn't become our policyholder. But people get into positions of weighing, do I want to go for my colonoscopy or not? The genetic test would have helped him make that decision.
Thank you.
Okay, I know there are more questions, but we have other witnesses. And I can see the interest of the committee, right? And I think what I would like to do, and I'm gonna propose it later, is that I think I'd like to turn this bill into a work group. And I want to get some information from Florida, right? I want to see whether the sky has fallen. I want to get some information on the data set for the last 5 years. I want to see if any companies have gone out of business. I want us to compare apples to oranges, what's happening in the other states, okay? Because I could see the interest of the committee. Does that sound like, okay? And we'll talk to the sponsor of it. So Matt, just letting you know so that you can participate. But I think that there's a lot of interest and we're gonna do it in a smart way, okay? That being said, any other questions? Seeing none, thank you so much. And thank you for coming. We really appreciate your testimony today,
Well,
okay?
thank you for your thoughtful questions. Appreciate it.
No, our pleasure. So we have next Lisa Peabody, Aaron Wright, John Hoffman, and will you bring Kuldip Dave? And I think that's it. Anyone else that didn't get called? Is there someone here that did not get called? Come up, please. All right, and bring anyone that is virtually too. Will you please get started?
Yeah, I'm going rogue on my testimony, so we're just going to see how it goes, because I want to respond to some of the messages from our opponents. And my name is Lisa Peabody. I live in Bethesda, Maryland, and I'm here representing Maryland constituents as part of FORCE. FORCE is a national organization, and we advocate for the needs of people with a cancer genetic mutation like the BRCA1 that you mentioned, but there's over 40 genetic mutations. It puts people at risk not only for breast cancer, but ovarian, endometrial, colorectal, pancreatic, gastric. So there's more than just breast cancer. And despite what our opponents were saying, people are definitely being denied in my community. I have so many stories across the nation of people who cannot get life insurance or disability insurance. And we heard from only one plan, that's the New York Life plan, but there are other plans in Maryland besides New York Life. And so maybe they're being characteristic and considering the whole, but we are finding that people are being denied. And if you put that into dollars and cents, like it's so important to the lobby group, if you don't allow someone to have life insurance, then when they pass away, and if they pass away early from cancer, who is left to pay for the family? This family ends up often being cared for by the state. So we want people and families to be able to purchase life insurance, even if they have the risk of of cancer. The other argument about, it's escaping me. this idea that just because you have a marker, it does not mean you're going to get the disease. And in my situation, our community can take great measures to mitigate that risk by colonoscopies starting at age 25, zapping those polyps before they turn into cancer, supplemental breast screenings, removing their ovaries. So that idea that just because you have the mutation, you're going to die early of cancer is really not the case. It's just a risk marker. It isn't the disease. We're not taking that away from them. They can look at disease. We just are taking away this risk marker. Thank you.
Thank you. Next, please.
Thank you, Madam Chair, Vice Chair, and the subcommittee. My name is Shayla Harris, and I work for the American Kidney Fund. I'm also a 15-year kidney transplant recipient and a breast cancer survivor. I appreciate the opportunity to speak with you all today about an important issue on behalf of all the people that we serve in Maryland, including more than 18,000 residents currently living with end-stage renal disease, also known as kidney failure. We respectfully request your support for House Bill 1007. This important bill would ensure the patients facing chronic disease, such as kidney disease, do not face the discrimination of increased rates in life, long-term care of disability insurance solely due to receiving genetic testing. The American Kidney Fund is the nation's leading nonprofit organization working with 1 in 7 Americans living with kidney disease and the millions more at risk, with an unmatched scope of programs and support people wherever they are in their fight against kidney disease, from prevention through transplant. With programs that address early detection, disease management, financial assistance, clinical research, innovation, and advocacy, no kidney organization impacts more lives than AKF. We're also one of the nation's top-rated nonprofits and have a 4-star rating from Charity Navigator for 24 consecutive years. One of American Kidney Fund's top priorities is to advocate for reducing health disparities. And we believe that healthcare access and affordability are critical components. Without action to expand coverage of promising services like biomarker testing, advances in precision medicine will likely lead to an increase of existing disparities in health outcomes. We encourage individuals with risk factors to pursue genetic testing to help make decisions around preventative care and to manage kidney disease before it becomes kidney failure. This we submit to you today is simply a good public policy, which is why we respectfully request your support for House Bill 1007. Thank you.
So are you testifying for John Hoffman?
I am not. I'm testifying on behalf of American Kidney Funds and the 35 million Americans with kidney disease.
You're not signed up. You're not on my witness list. So what I need you to do now, because you did not sign up, is that I need you to go, when you're finished, to my office. Sure. Because now we have to fix it.
Okay.
Because there are rules, you have to sign 2 days ahead, but it's okay, I permitted it.
Okay.
But I need you to help me straighten out the record.
Sure. John Hoffman was also our representative at American Kidney Fund. I'm assuming that I'm speaking on behalf of him as well.
Yes, because he's the one that is signed up. That's why I
Thank you.
asked. You're welcome. I wasn't going to interrupt you, so that's okay. Just help me straighten it out.
Will do.
And thank you. Thank you for your testimony and for being here. Next, please.
Good afternoon to Madam Chair, Madam Vice Chair, and the members of the committee. My name is Dr. Erin Wright. I am a constituent from Baltimore, and I'm an advocate with the Ovarian Cancer Research Alliance. I strongly support House Bill 1007, which would protect Marylanders from genetic discrimination in life, disability, and long-term care insurance. As a certified nurse midwife with doctoral training and a professor at Johns Hopkins University School of Nurses, I provide services to those assigned female at birth, and I know firsthand how vital genetic testing can be in saving lives. In 2021, I was surprisingly diagnosed with a stage 3C high-grade ovarian cancer. The 5-year survival rate for my particular cancer is 5 years. I'm on year 4. Genetic testing provides critical information that empowers individuals to make informed medical decisions, yet the fear of discrimination prevents many from accessing those potentially life-saving tests. BRCA1 and BRCA2 are two of the many genetic markers linked to some ovarian and breast cancers. Early detection and preventive care, which could be afforded to patients by these tests, can mean the difference between life and death. No one should have to choose between protecting their health and family and securing their financial future. While the Federal Genetic Information Non-Discrimination Act prohibits genetic discrimination in health insurance, there is currently no such protection for life, disability, and long-term care insurance. This gap in the law disproportionately impacts those with a family history of cancer and other hereditary conditions. HB 1007 would ensure that Marylanders can undergo genetic testing without fear of financial repercussions or discrimination, fostering a healthcare environment that prioritizes prevention and early intervention. I urge this committee to support House Bill 1007 and protect the privacy and well-being of Marylanders seeking to take proactive steps in managing their health. Thank you.
Thank you, and I'm glad you're here. And
Thank you,
you're
I am
doing
too.
well, okay, thank you for sharing your story. Next, sir, Mr. Koldev Dave.
Hi, good afternoon. My name is Dr. Kuldeep Dave, and I'm Senior Vice President for Research at the ALS Association. I appreciate the opportunity to speak to you today in support of House Bill 1007, but more importantly, in support of the more than 200 families with ALS we currently serve in the state of Maryland. ALS is a devastating neurodegenerative disease that progressively robs people of their ability to move, speak, eat, and eventually breathe. For decades, it was thought that once this deterioration begins, there is no way to stop it. However, a genetically targeted therapy called Qalsody or tofersen, which was recently approved by the FDA, is proving that wrong. Real-world data from Washington University in St. Louis, as well as from Europe, is showing that people with a genetic form of ALS called SOD1 ALS can actually regain function after starting treatment with Qalsody. They're going from being unable to move to lifting up a glass of water and drinking from it. They are getting better. Because of the targeted nature of this therapy, only people with SOD1 gene mutations can benefit, significantly increasing the importance of integrating more routine genetic testing into ALS care. But we know from a survey of 800 people that we just completed that many people living with ALS are afraid to find out their genetic status. 20% of survey respondents indicated that they're unlikely to get genetic testing because they felt that they would lose their long-term care, disability, or life insurance. And nearly 30% thought their families would lose their benefits if the results were positive as well. So you can see the threat of genetic discrimination creates a serious dilemma for Marylanders. Risk the opportunity to potentially improve their physical health because they don't know their genetic status, or risk their financial health because they do. Bill 1007 would remove that threat, help improve the health of Marylanders, and accelerate the massively important science being done in this state. I urge you to support it. Thank you for your time and consideration.
Thank you very much for being here and for taking time to give us your testimony. I'm going to open it up for questions now. Are there any questions for this panelist? This panel? All right. Seeing none, thank you so much, okay?
Thank you for your time.
Really appreciate you. And this actually concludes the testimony on House Bill 1007. If you can stay seated while we go down, give me 1 second. Will you bring us down, please?